2, 2, 10, 2. Probă. Doi, 2, 10, probă. Doi, 10, 2, probă. 2, 10, se aude? 2-10.
Okay. Oh, have to be careful with this. Okay. Hello and good early afternoon. Welcome to the first in history SGRT meeting, community meeting in Romania. I welcome everybody in this beautiful city of Cluj in Carpathian Mountains. I'm glad to be here and be one of the hosts together with our partners. Together with SGRT community, Vision RT as a company and our partners in Onca Systems, we're happy to bring this opportunity here in Cluj to expand and deliver more of the clinical results and clinical usage of the SGRT as a new way of doing radiotherapy in the market. Few words about the company. Vision RT, as a founder and developer of the SGRT system, was founded about 20 years ago in UK, London. Can you decrease a little bit gain? Thank you. So since then, the SGRT as a usage as a technology in radiotherapy market has expanded to means where it is becoming very quickly the standard of treatment. I'm pretty sure in few years around the world, people will have a very, thank you, a little bit, yes, I think it's a little bit better. In a few years, people will be wondering how we were able to do those types of radiotherapy treatments without the SGRT technology. At this stage, the company grew from a startup from 20 years ago to more than 250 employees, out of where 70 people just work in development of the product and bettering the product for all the customers around the world. We're the pioneer and developer of this technology to the radiotherapy market, which really enables a real-time 3D motion tracking of the patient while the radiation is being delivered and even before the radiation is put to the patient's body. The company holds more than 80% market share worldwide of the SGRT systems, with over 2,000 installations around the world, where the centers utilize it globally for different types of treatments, from beam hold to very accurate treatments like stereotaxy for head and neck areas and for the body. But really, most of the things are driven from the patient education and from the end user education. So this is why the SGRT community was created with partnership with the Vision RT. The SGRT community is an independent organization that is really made there for the peer-to-peer sharing, where end users can share and can advertise and show their best practices of radiotherapy treatment within the world. Company at this point hosts 3 Queen's Awards, which is the only company in the history of UK to get this prestigious award 3 times. And since 2007 has created and expanded the SGRT community from about 60 members to more than 11,000 members worldwide. So what is the real strategy, or what is the goal of the SGRT community and Vision RT as in general? So the goal is really aligned. We must bring this technology as a means for standard of care, for motion management, for all radiotherapy treatments. Whether we're doing this for the beam hold or interfraction monitoring around the world. So we're leaders in technology. So we're a leading company in manufacturing the 3D camera systems for optical monitoring. We are expanding internationally quite rapidly, and we have more than now 2,000 installations around the world. And we are also educating our patients through the patient education website called AlignRT.edu, and helping and share the best practices of SGRT usage within the market and within the peer-to-peer sharing, utilizing the SGRT community means. SGRT community is there to, you can become a member of the SGRT community, and it's free to join, and everybody can become a member of the scientific research community. You can learn a lot of things, best practices, exchange best practices for treatment, share treatment ideas between each other, and results. You can ask questions and get the feedback very quickly, because we have a lot of members within this community that can actually have been using AlignRT system as an SGRT standalone system with their own Linux during the many years of their clinical practice. We do many scientific events which are free to join, and we do many regional events within the countries and the regions as well, which SGRT community meeting in Romania is one of the examples of such events. So all of those events are free to join for everyone, free to attend, and you're most welcome to check information about this on SGRT community website. The SGRT community also has the independent scientific committee and a chair that really moderates all the information that goes through and helps to disseminate the best practices between the end users around the globally. And we do two main conferences. We do a conference in UK, which is for the EMEA region, and we do a conference in US for the SGRT meetings. So the conference in US is upcoming. It's going to be in June as well, in the Washington, DC area. It's again, you're welcome to register and join. Again, no fees associated with it. And of course, you can really easily scan this code or go to this website to become a member today. So thank you for coming, and thank you for attending our SGRT Community Romania meeting. together with Vision RT and Oncosystems, they are partners within the region, and hope you enjoy this opportunity and hope you had a good knowledge sharing sessions during the day. Thank you very much.
Thank you for the introduction, and I would just welcome our invitation guests and participants. My name is Renata Zahu. You know, I work in the Amethyst Clinic, and we are happy to use the system for quite a bit of time now. And I think it's a premiere for Romania and for Cluj that we have the technology coming to us. Previously, I think it was an option just to go to a conference and see new technology there. And I think we should appreciate that vendors are opening to the users, and they are coming and showing us what is available to offer better treatments. So it's a shift in radiotherapy to this surface-guided radiation, and Mr. Irakli Martashavili will present us a short introduction about this shift and how in the future our practice probably will change. Thank you. Please.
Thank you for introduction. I'm going to give you a bit of a general talk and talk about worldwide SGRT use practices and how utilizing the surface-guided radiotherapy is shifting a little bit the usage within the radiotherapy field. So I work with Vision RT. This is my third year within the company. I work as a clinical medical physicist, consultant there, and also application specialist within EMEA region. So this is my, I think this is my third time in Romania. So I'm glad to be here and be again a beautiful city in Cluj, in Carpathian Mountains. So we, as a company, when we were thinking about why we would do the SGRT or why we would really bring this technology to the market, as from the clinical perspective, if we just take a step back, we saw there was a particular need in radiotherapy which was not truly and duly addressed. So the first of all is, of course, it's a treatment demand. So we know we have to, treat more patients with the same amount of resource or same amount of linacs. And we know the global demand of radiotherapy and global demand for cancer care is increasing from, let's say, from year to year. And oncologists are the most aware of this because they see these trends, worldwide trends everywhere. So we need to have really the accurate, fast solution for patient positioning in our case, to basically treat the patients faster. Because if you look at the breakdown, the timing of the patient treatment, we see the positioning and accurate positioning, submillimetric positioning of the patient in table takes the bulk of the time from the treatment. But on top of that, even if we produce the best positioning, if we align the patient in the best way on the table we manage, the patients tend to move. And the more time they spend on the table, the more the likelihood of their motion on the table increases. So really, before the SGRT, this was an anecdotal evidence. So we could see, okay, we positioned the patient best, we left the bunker, we came out, and we see the patient maybe shift to the posture. But we had really no means to verify this except doing more and more internal imaging. So really, interfraction motion as component of the live component of the radiotherapy treatment needs to be addressed. So we found that need as well as a missing piece of puzzle, that we need a solution that accounts for that interfraction-like motion. So if you look at how we did it traditionally, and I as a clinicist for working as a medical physicist several years, we utilized many different workflows in the clinic to address those. We use tattoos and marks, and many centers around the world still use them to position the patient according to the bunker lasers. A lot of patients do not like them as well, tattoos on their body as a permanent reminder. And marks are, if the marks are semi-permanent, they are also not as reliable, can be easily removed off the patient's skin. Immobilization equipment. A lot of centers utilize immobilization equipment that are quite restrictive and uncomfortable for the patient. For for bad, we are not using the metallic frames that widely anymore. We went to the frameless stereotactic treatments, but a lot of times there's still a lot of number of claustrophobic, invasive, or quite restrictive immobilizations still used up to this date in this case. For example, thermoplastic masks for head and neck treatments are quite, again, still a standard for radiotherapy at this point. To verify the patient positioning, a lot of imaging was done. In this case, internal imaging, of course, gives you an idea of patient information and position right at that moment. But, of course, if you want to do a live imaging, address the interfraction motion, you have to do more imaging. So it's not real time, or you have to do a fluoroscopy with added imaging dose for every treatment of the patient. And the third one is, of course, the breathing. So the breathing motion is important to maintain and take into account. A lot of times our targets move with this breathing motion, either periodically or semi-periodically. And a lot of times the surrogates have been used to address those, like the block on the abdomen or the chest, or the specialized devices that measure the volume in the lung. So when we talk about really the shifting, paradigm shift during the radiotherapy and why SGRT is becoming quickly the standard of treatment, is something like this. So if we take a singular system, non-invasive, fully optical, no detriment to the patient, we attach it to the ceiling, it can either completely take out or completely substitute all of those, let's say, normal clinical workflows you see in your department, or substantially reduce the frequency of those workflows you have to do. So let me show you a few examples of how this is done and what the SGRT system kind of looks like. So this is what you would have in a normal C-arm treatment bunker. So you have 3 cameras poised around the ceiling. So these 3 camera pods, we have 2 stereoscopic cameras inside of those and a singular projector in the center. So we project from those camera pods a specialized speckle pattern onto the patient surface and reconstruct this as a real, let's say, spatial points, or let's say a virtual contactless tattoos on the patient's skin. So this is a fully video-based optical 3D surface monitoring system of the patient, and it can be used for setup and interfraction monitoring. And since it's non-ionizing, non-invasive, it can be utilized from start to finish, just even before you deliver your radiation, even after you deliver it, and post from end to finish for the whole workflow. So again, we can utilize the same patient surface, the 3D surface. We can match it to your DICOM reference. So you can have a reference coming from your CT scan. We make sure the patient is aligned in all 6 degrees of freedom to your isocenter, to your treatment isocenter, and we also make sure your patient's posture is corrected to the same geometry as you had in the CT sim. And because we can monitor the whole surface, we can do interfraction monitoring, we can do this in whole 6 degrees of freedom, and we can also auto beam hold when, because we have a feedback connection to the LINAC, so we can hold the beam in patient without tolerance, and those workflows can be facilitated as well with interfraction monitoring or with the beam hold gating as well. So this is what it looks like. So those cameras project a speckle pattern into the patient's skin. It can be kind of visualized here with the video screen. Then our software actually takes the live video feed coming from the cameras and turns them into, let's say, a 3D surface. And this is the reason why there are 3 cameras around the bunker, because not each one singular camera will see the full picture. So you need kind of a combination of the 3 points of view, because the patient surface will be occluded by self-occlusion. So the camera from the left will just see the patient's left side, so will not see any information from the right. So we combine the information from 3 cameras to have a full singular surface for 6-dot monitoring. And of course, we match it with your isocenter to your DICOM reference. So again, whatever way you scanned your patient at the CT sim, we repeat the same geometry in treatment, even prior to delivering any, let's say, X-ray radiation, any kind of dose to the patient. making sure the patient is accurately aligned to the table. And of course, since we feedback this everything to the LINAC, we discern the patient's position in 6 degrees of freedom. We take this information to the LINAC, and then we can do auto beam hold if necessary and perform those interfaction monitoring and beam hold gating type of techniques. So this is how this works. So from treatment planning, we take your reference, we take your plan, your isocenter coordinates of the plan, and we take your external body contour. We, let's say, import or send this data to a LineRT system where, let's say, somebody, usually these are the people working on a machine, prepare or do a preparation, let's say, process here. They select the areas they want to track. We select, for example, if we're treating the left breast here, we're selecting the breast and surrounding chest wall tissue. And we're tracking this target in real time with 6 degrees of freedom. And we can deliver the treatment by live tracking the target, making sure the position is reproducible. And if you're using the beam hold techniques, we're making sure the target's position is reproducible from one beam hold to another one. Okay, so really the Vision RT's goal here is not just giving them more information and sharing the best practices to the end users, but educating the customer as well. So this is why we have Safer Radiation Therapy portal, which is geared towards the patients. We have a lot of information there, why the SGRT technology is beneficial to radiotherapy treatment. It's actually explained in a patient's way. A lot of clinicians and doctors and radiotherapy professionals utilize this to give more information to the patient and educate the patients about the benefits of SGRT technology. All the centers in the world that utilize SGRT in their treatments are also listed there. So you can go in, the patient can go into the website, type in their own city, and they can find the nearest center that utilizes technology for treatment. We have Safe ID product, which is a patient contactless biometric identification system and accessory identification system as well, which can be installed from reception down to the simulation at treatment bunker. The patient can come into the reception, stand in front of the biometric camera, identified, and then guided through to the simulation or the treatment bunker. There's a SMRT product, which is a singular pod system for CT simulators, where we capture the patient's surface. We select the respiratory point on the patient's surface, and we can record the respiratory curve at the CT sim for DIBH type of treatments, let's say simulations, or for the CT type simulations at the CT sim. Again, fully contactless without any need for external devices. And again, AlignRT Advance, which is our main, let's say, main product installation around the world, which utilizes those 3 cameras, as I mentioned, to track the patient in real time and deliver the treatment with interfraction monitoring and beam hold gating as well. And the newly released AlignRT Inbore, which is a hybrid product with the ceiling cameras and small miniature cameras inside the bore of enclosed accelerators like Halcyon and Ethos to, let's say, set up the patient outside and also monitor and track the patient inside while the radiation is being delivered in a closed geometry. So when we talk about AlignRT and usage of AlignRT, this is the benefit here. So all of the sites you see here on the slide, there's a clinical publication associated with it. At this point, AlignRT has more hundreds of peer-reviewed clinical publications associated of using the SGRT system, I'd say, in treating one or different treatment sites. And we can really see benefits from head to toe for all types of treatments. So what are those benefits really? So first of all, as I mentioned, the faster and more accurate patient setup, where we make sure the patient is set up not only correctly at the isocenter, but the patient's posture is also corrected. We utilize SGRT technology as a complement to the internal X-ray imaging to make sure the setup accuracy increased, but also the interfraction monitoring is maintained versus to verified position after internal imaging is done. and tattooless and markerless positioning, which is, again, a clear benefit for the patients, where we utilize virtual tattoos and virtual positioning to make sure the patient is aligned well enough in center without the need for marks on the patient's surface. On top of this, we monitor the patient in real time. We update patient's position up to 27 times per second. We are monitoring the patient's positions in submillimetric way. So our tracking accuracy is under 0.3 millimeters and 0.2 degrees for all clinical scenarios. Even if you rotate the couch and the gantry, occlude one of the cameras or block the view from one of the cameras, that accuracy of patient tracking is maintained. And we're also controlling the beam, of course, in all 6 degrees of freedom. I mentioned the postural setup is important with the LineRT, and in this case, we utilized the subscription feature in the LineRT called Postural Video. What you see here on the right is really a global positioning tool, where we take the live video feed from the cameras overlaid on top with this pink guidelines. So these pink guidelines are coming from your reference surface and are auto-generated by the software. So this immediately tells you, so whatever way your patient was situated at the simulation, and how to repeat that geometry right at the table from first fraction to the end fraction. You can cycle the views from different cameras. As you can see here, like here in this mock setup, here on the tassels, we have the similar setup there. We can cycle between different cameras to look and, let's say, check out and discern patients, let's say, the patient is not aligned well enough on the table, and where the correction needs to be done. If the patient arm is, let's say, has moved, in this case, if the patient's arm is out of tolerance, if the patient's chin is not in the same place, if the torso is rotated, if there's inherent roll or the pitch associated with the patient's position. So this is how we can really easily, very effectively and quickly correct the patient posture. On top of the other things, on the left, you see your real-time deltas. So these deltas in 6 degrees of freedom are calculated with respect to the isocenter. So we know where the patient is and where the patient needs to be, and how much we need to rotate and shift the patient, put the patient right at the isocenter. The good thing is, since we have the feedback with most of the Linux, we can actually send these deltas to your robotic couch, and robotic couch can do the work for you. So you don't need to free float or manually move the patient. You can take these deltas, send it to the couch, and the couch can drive to the isocenter by itself. So quite easy and efficient setup. A lot of our centers, they utilize those types of workflows, postural video plus automatic couch move options, can set up their patients on the table well within 1 minute time slots in all 6 degrees of freedom. Another really interesting feature that the LineRT Advanced has inside is the surface deformation, which gives the idea of how patients' geometry changes during the first fraction of the treatment from the simulation down to the end. And you can, the best thing is you can quantify these changes. So here, for example, this is showing some, let's say, seroma buildup or the swelling in the breast. And this red overlay, color overlay, means the surface has swelled or there is a little bit of, let's say, seroma buildup underneath. And on top of that, you can quantify here how much of your target area is within certain tolerance. So we can discern here changes as small as 1 millimeter. And we can say here with certainty that about 93% in this case of our target area is within 3 millimeter tolerance. So it gives you the idea of what kind of geometry changes you have and where you have to address it dosimetrically. If the color overlay here is blue, that also means a receding surface. It could also mean a weight loss or something that's happening internally underneath the patient. But not only you can quantify for your own regions of interest or the targets you're treating, but you can see the same thing for your full field of view of the camera, so you can address this over the whole torso of the patient. I'll go a little bit into the more clinical benefits. So first, in real, the first treatment site the end users really start to utilize SGRT system heavily is, of course, doing the deep inspiration breath hold treatments, and especially for the left breast patients. Published data has shown that's a particular clinical benefit to it as far as the normal tissue organ sparing comes. And when we look at here, one of the published data from our end users, when they looked at the cohort of the left breast irradiation patients, they did SPECT-CT analysis. So they did the SPECT-CT analysis on those patients prior to radiation and 6 months post-radiation as a follow-up. They gathered the combined cardiac perfusion score on the SPECT-CT, and they found that with the left breast irradiation, they found no worsening of the cardiac perfusion scores or no indicated added damage to the left breast when they performed the DIBH with the Line-RT. So the end users were quite surprised. They tried to compare what data is available there in the literature. They found this study from the Duke University, which showed that if you're not performing the DIBH, that number can be as high as 27%, or let's say, 1 in every 4 of your patients get significant or meaningful heart damage from the left breast irradiation. And this is truly because end users could really see that they could reproduce that really chest rise, that really breast position from one breath hold to another breath hold, where we can monitor and truly look at the position of the breast itself. So when we talk about successful DIBH treatments with a Line-RT, we start really at the simulation. We start gathering our reference data. So a recommended step here is to have a free reading scan at the simulation, which is utilized then for patient setup with postural video and adjustment of the patient at the table, and a breath hold scan, of course, which is used for treatment and dosimetry. So here, with a free reading scan, we are positioning the patient initially on the table. And when we go with the breath hold, we coach the patient in the breath hold. We make sure the patient can achieve that chest rise, can achieve that reproducibly in 6 degrees of freedom, including all translations and all rotations. And then we are verifying the breath hold, and we're treating in breath hold with the gating and connection to the LINAC as well. So since this technique is quite reproducible, can be used not just for the breast, for any other sites you want to treat with breath hold. If you're delivering lung or liver SBRT with deep inspiration breath hold or expiration and end expiration breath hold, you can utilize this technique for full 6-step monitoring. Just to go a little bit further down, to move more into the accurate types of treatments, now we have a Line-RT used by about 300 centers around the world for SRS and SBRT treatments. Because we can see the proven benefits, we can see the proven accuracy of a Line-RT and real-time monitoring benefits in those types of treatments, where we could make sure the patient is really staying for that really accurate dose delivery, really very fine and very sharp dose gradients that we need to facilitate those treatments with. But of course, positioning here is a challenge for those types of treatments, especially when it comes to something like a non-coplanar treatments, like for non-coplanar SRS type of treatments, where we can verify the patient's position at couch 0 for serum LINACs, but then as soon as we go to a non-coplanar angle for better dose fall-off and better clinical outcomes, our gold standard for imaging is not there available for us. So SGRT can help you in this manner because we can track the patient's position in real time post-imaging, and we can make sure the patient is maintaining that position and they are staying within the position within the tolerance, and the treatment can be delivered safely and efficiently. To show you how this is done, and this is done because the Line-RT is calibrated in a specific manner. Not only we have a calibration tool that you can utilize to calibrate the system according to your external left reference, like lasers or the field lights, but there's a specialized cube phantom with embedded radio PAC spheres where we automatically find the radiation and the radiation isocenter of your system, of your LINAC, and make sure the camera isocenter or the isocenter of the cameras where the camera sting isocenter is directly correlates and coincides with that system, utilizing automatic, let's say, a sphere recognition, automatic pixel-based analysis algorithm, which we can make sure that accuracy is maintained. So all of those things together, this type of calibration, plate calibration, and something we call advanced camera optimization, which is a very unique type of camera calibration at the installation stage. This is done, gives us this best-in-class accuracy of SGRT system in the world. So it gives you the tracking accuracy of under 0.3 millimeters and 0.2 degrees in all non-coplanar treatments, including all challenging clinical cases when the isocenter is far below the surface, where you have the camera occlusions available, happening to you, and we're maintaining that accuracy for those types of treatments, which is quite well sufficient for those types of challenging non-coplanar SRF treatments. Just to show you a little bit of a workflow, what it looks like, of course, we take all the data from the planning, your external body contour, your planning CT, and we're utilizing the open face masks for those types of treatments. So we're making sure that we're tracking the opening inside the mask, you're tracking the patient's skin, we're tracking the face, and it also gives you a better accuracy with increased patient comfort. So you don't need to use any more the closed-face masks to maintain that particular sub-millimetric, sub-half millimetric accuracy. So we're importing the patient's data, we're delineating our region of interest, which is this facial opening in the mask, and of course, at this stage, you want to perform your internal imaging. So you want to use your gold standard for patient positioning like CBCT. And of course, post-CBCT, this is where hybrid workflow of IGRT plus SGRT shines, because not only you verify that position at the zero-gain triangle, but you have to imagine you have to track this when you're going non-coplanar. But non-coplanar CBCT doesn't exist for you. Only planar imaging is possible. But with a line-RT, you can do a full 3D, let's say 6-DoF monitoring, because at this stage, a line-RT can capture with the cameras the new reference and can track this new reference in real time while you are delivering the radiation to the patient. So you can track, if you go to a non-coplanar manner, it can be tracked, and the beam hold can also be done if the patient moves out of the tolerance. And all of this is, of course, supplemented with a lot of clinical data. There's a lot of publications associated, whether we talk about malignant mets for SRS with a very good clinical outcomes, benign tumors, 5-year follow-ups, single isocenter multi-met treatments, or trigeminal neuralgia treatments with a single fraction, 80 to 90 gray deliveries, and open face masks to boot. But of course, we don't stop there. SGRT means for Vision RT really just the innovation. So we want to bring new, let's say, features, new solutions to the market. One of the new ones we brought into the market is something that we found out that the market was lacking. It's a SGRT solution for full interfraction monitoring, beam hold gating for closed bore geometry LINACs. So this is where the Line-RT inbore was born. The Line-RT inbore is a hybrid solution with the ceiling cameras and the ring-mounted cameras inside the gantry. And you can see a model of that camera ring right there at the stand, and you can have a close-up look at the demo as well. So when we started to look for this clinical benefits for those types of enclosed LINAC geometries, we found out that first of all, we could bring the benefit of the patient setup with SGRT to this. So we started partnering with one of our clinical research centers. This is Orlam at the Macon, France, near there's a center, halcyon reference center near Lyon, which has 6 halcyons inside. So they were really looking into find out the benefits for the treatment and for patient setup initially. So we started with the ceiling cameras here. We found very quickly that not only they they found the benefit for the patient setup time on the LINAC, but as well as the accuracy versus tattoos. And this all translates into the setup accuracy, because very quickly, when they looked at their cohorts, especially for the breast, they found out this large translations that stemmed from the rotations at the IGRT workflows were gone as they moved to the SGRT-based markerless setup, where you can see that not only the shifts now are smaller, more consolidated, but the outliers with larger shifts of shifts than more than centimeter now are almost eliminated. But really, for them, the holy grail here was the beam hold. So they wanted to do DIBH, and they wanted to see if we could perform this with ceiling cameras. So we went out and did many different investigations. We mounted the cameras to different supports. We shifted the cameras towards the gantry that looked more into the bore. We tried to mount cameras at the back wall, but every time we really tried to see what kind of surface coverage we would get, we found out the surface coverage was really lacking for true 6DoF monitoring gating workflows. So we couldn't find that the same clinical benefit that we would see with the C-arm LINACs with just the ceiling cameras for those enclosed geometries. At this stage, it was clear, because of all the occlusions we could see and all the surface were missing, a dedicated SGRT solution was needed for those types of geometries. And this is where the innovation came with. We significantly reduced the size of our SGRT cameras. Now the inbore cameras can fit on the palm of your hand. So they are small, and they are very just a little bit over the 100 grams. So again, a very specific hardware innovation that made this possible. We have the same ceiling cameras, again, the same benefit for the patient setup with outside with postural video, the same postural corrections and isocentric setup in 6 degrees of freedom. But as soon as the patient goes into the bore, now inside bore cameras turn into action and can do full 6DoF monitoring for those types of patients. I'll skip a little bit over the summary, just gonna give you a bit of a taste of our new developments. So for example, we released the SIM-RT as of this year. So this is a new, let's say, respiratory management product for the CT simulators, where you can capture the whole surface, select the respiratory point, and then monitor this point in real time and record the respiratory data for either the DIBH type of simulations or to facilitate for the CT simulation. It comes with a visual coaching device that's similar that you would have also on your treatment machine. So you can hold and do, let's say, DIBH coaching sessions on the CT sim and make sure the patient's breath hold is reproducible, and we can coach the patient and prepare them for DIBH treatments on the LINAC. In the same manner, this system is fully contactless. There's no external devices touching the patient, and we can perform both DIBH, as I mentioned, and 4D CT simulations, because we can also interface with the CT sim and can also send this respiratory data to the CT sim for those types of workflows. But of course, Vision RT, as you start to learn the Vision RT, you will find that the innovation does not stop there. And with innovation, we try to now go further, try to see what is beyond now normal SGRT, how we can bring and how the SGRT can change the face of radiotherapy treatment itself. It's a challenging and very ambitious task, so to say, but really for this manner, we started to build our Horizon cameras. The Horizon cameras were released in December of last year, and now they're available on the market. You can also see them mounted on our tassels here in our reference reference setup here. And Horizon cameras are really the ones that are built for the future of SGRT and built to advance the means of radiotherapy into this field. So what's the difference? Why do we want to build new cameras now on top of our existing really good cameras, HD cameras that we have now, many installations, 1,000 installations in the market. The thing is here, additional features that are not, let's say, privy to the HD cameras. First of all, we increase the hardware capabilities of the cameras. They are now have the best resolution of any SGRT camera in the market. They are mounted with a double projector, so we have the double projectors in there. They project the light in infrared, which is fully invisible onto the patient's skin. You will see the examples during the demo at the end of the day. And best and foremost, they are Cherenkov enabled, so they can actually look and interface with something called the beamside cameras, which detect Cherenkov light to build a dose fluency on the patient surface while the radiation is being delivered to the patient. So the first time in history, we're not only tracking the patient's position in real time, but we're also tracking how your dose is being delivered to the patient. It's quite a bit of an eye-opening. But let's see what the Horizon cameras can really build into the radiotherapy. First and foremost, we see there's a need for non-coplanar treatment. So as we go into the more advanced stages of radiotherapy, we see many cases where we have the patients that come for retreatment. We've received the prior doses of radiation, or we have challenging cases where the really normal organ tissue sparing is important, like challenging SGRT cases, head and neck retreatments, and so on. And we've known this, and physicists known this quite well in the doctors, so that the non-coplanar cases allow you to decrease your dose fall off, your dose gradient well enough. And it's beneficial to the patients, beneficial to the clinical outcomes. But the problem here is you have many unknowns there. You have many collisions within the patient, within the gantry, couch, etc. The first thing we're building with Horizon cameras is a full acquisition of the patient surface. So we have that full acquisition there. We can, even prior to delivering the radiation, we can see where those collisions are happening, and we can build you the full collision map with respect to your IDA center, which fields could clear, which fields will not clear, and etc. But if you look at this like this, it's only, let's say, virtual dry run. We're utilizing and interfacing and working with the treatment planning systems to give this information now into your treatment planning system, where you have now additional degree of freedom, where you can generate much more nicer, better plans, better dose fall off, better organ sparing, and also increase dose escalation. But this is not all. I mentioned Cherenkov radiation. Now we're interfacing with the beamside cameras together and discern, let's say, how the dose is being distributed onto your patient's skin while radiation is being delivered. So the system is going through the clinical testing. It will go through the initial limited clinical release soon, and initial, let's say, site where we're doing the clinical testing here in Dartmouth, very prestigious college in US. We found out that about 4% of patients have some kind of incidence, or let's say within the treatment, that can only be caught by real-time dose imaging capabilities of the dose RT. So for example, here you have a sweeping MLC with the carriage motion, which is not detected by your patient-specific QA, but can be easily visualized by the real-time dose imaging. Here, for example, you have a bolus missing at the exit of the dose, or the exit of the field. And this is, again, quite common. You have a treatment delivery, but your patient moves either the chin or the arm into the beam line, and now you have added, an undesired dose to the normal organs of tissue, normal tissues. So this is what the beamside camera looks like. We have exclusive contract with the manufacturer here, and we'll be the ones exclusively providing those cameras to the market as the dose RT product, and of course with the dose imaging. Just at the end of everything, I want to give you a bit of a taste what this might look like in the future. So this is the video from the publication. So you can see a few things here. On the left, you see the real-time, real chunk of light registered by the cameras. In the center, you see your MLC profile projected onto the patient's skin here. And here at the last image, you see the dose slowly being accumulated and displayed as additional dose forms onto the patient's skin. Okay? So this is what the Vision RT is working on and new things we're bringing with Horizon cameras, and we'll be happy to be changing, not only monitoring the position, but also the dose in real time with our future products and Horizon cameras. Thank you very much. I think I went a bit over time. And if you have more questions, you can ask now, or you can get my contact information. I'm more than happy to answer them in the future. Thank you very much.
Thank you. My proposal would be, thank you for your presentation, to have a QA session after the first 3 presentations, because probably you have questions, and some of those questions will be answered with the next 2 presentations. And the following one will be presented by Professor Alina Mihai. She's a radiation oncologist from Ireland, from the Beacon Hospital, and she's going to speak about precision in radiotherapy from the point of view of doctors and also the experience of the patient during radiotherapy.
Good afternoon. It is my pleasure to be in Cluj again, the city where I started radiation oncology. It's nice to see some of my old colleagues, and it's nice to see very young faces around here. So you had a very technical presentation before. Now I am trying to show you over the next 30 minutes or so how this technology improved the outcomes of the patients and the comfort and safety of the patients treated when using this technology. A little bit emotional to be in Cluj. I'm a consultant for Vision RT. So some of us remember how the radiation therapy advanced from the 2D type of treatment up to being able nowadays to treat using functional imaging. We are able to monitor and manage the motion. And we are now able also to treat very small targets very accurately within millimeters accuracy. I'm coming from a department where the majority of the patients are treated using high technology stereotactic radiosurgery or stereotactic ablative radiotherapy, which are require high precision, accuracy, and reproducibility of the treatment. This is important not only from technical point of view, but the patients will benefit, because this is a technique which is minimally invasive, usually does not require hospital stay, has very low morbidity, and is suitable for patients who are poor candidates for surgery or other ablative techniques. However, there are risks associated with this technique. We are using very large dose per fraction, so we are dealing with very long treatment times. So patient compliance becomes an issue. We have very tight dose distribution, so we have potential for geographic miss, and the tolerance of normal tissues to high doses of radiation is poorly understood. We have guidelines already published, both for intracranial and extracranial setting. And these guidelines suggest that imaging, planning, and treatment should be typically performed in close temporal proximity. The treatment delivery should be accurate within 1 millimeter. There is very little room for error in the overall process, and we need very strict protocols. So with all the technology which is available nowadays, one of the issues remains patient positioning and patient movement. And this is especially important for hypofractionated treatments where the treatment times are long, so the patient compliance is essential. There are several systems available for surface guidance. My presentation will focus on Align RT. These surface guidance techniques are more widely accepted nowadays in the radiotherapy facilities. And they can be used as you heard before, for patient positioning, monitoring before and after treatment to manage the respiration. However, and this is what I'm going to insist, these systems are imaging the surface. They are not imaging the tumor. Okay, so this is the first important message that you will have to remember. Why surface guidance? Because we can use it for the patient setup with an accuracy of isocentric setup within 3 millimeters and 0.2 degrees for rotations, is non-invasive, non-ionizing, and 3D real-time monitoring. Intrafraction monitoring allows corrections within the 6 degrees of freedom and automatically switches off the beam if the motion is beyond a certain threshold. For me, as a clinician, and for the patients, I think that the main benefit of this technique is the intrafraction monitoring. Increases the patient safety and the comfort and improves the clinical outcomes. So we'll have a better targeting and better sparing of the organs at risk. The indications of SGRT in radiotherapy increased over time. It started with the intracranial setting. We go to breast chest wall irradiation and deep inspiration breath hold techniques, hypofractionated treatments. I think that it will be extremely important in a pediatric setting and for adaptive radiotherapy. You saw these videos already. So for the therapists, for our team, it is very easy to follow what shifts are required. You see green is good, red is bad. And with the postural video of Align RT Advanced, you can easily see if the patient is moving, and you can monitor correctly if the breath hold gait is maintained. The therapists love it, absolutely love this tool, especially because the patient's movement less than 3 millimeters are very difficult to see with the naked eye. Again, message, this is a surface monitoring tool. So once you apply the shifts, you need to re-image and you need to do a cone beam CT after applying the shifts to confirm that the shifts are correct and the tumor is in the correct position. You heard about the benefits of this technique. However, what it is critical, absolutely critical in the process, is the definition of the region of interest. You need to, regardless of the area that we are treating, you need a stable portion of the surface. You need to avoid any part which is of the patient, such as gowned or immobilization devices. Avoid non-reproducible areas because of the motion or too much fatty tissue. You have here types of ROI definitions per region. So I'm coming from a small department, 2 linear accelerators, a team involving 3 physicians, 5 physicists, and about 12 therapists, a very, very dynamic team. We introduced the Align RT in 2014, initially for intracranial radiosurgery, and we moved over the years to use it in pretty much all the settings, not only in hypofractionated treatment, but also in the regular type of radiotherapy. And since August last year, we have the Align RT Advanced, which is used regularly in clinic. So my presentation today will focus mainly on the intracranial and hypofractionated settings, and I will show you some real data as we use it in practice. So we heard and we learn all the time that both in the benign or malignant settings, radiosurgery achieves very high local control, very little toxicity. And everything will be fine and nice if the tumors will be in the middle, no structure around. And as we know, usually the tumors are situated in very delicate areas near the optic ions, for example, or in the case of trigeminal neuralgia near the brainstem. And we can have very significant toxicities if we don't account appropriately for that. In the cranial radiosurgery, and we started here, as we mentioned, we have the frame-based approach where this ring was attached to the brain, to the skull of the patient. It was very uncomfortable. You required the neurosurgeon on site. It was a long day for the patients. The patients were really uncomfortable. Then we moved to the frameless or ZMED monitoring, like in these images. You can see that you required this mouth bite piece, which was quite untasty. I tasted it, it's quite not nice to have it in the mouth. You cannot use it in patients who are edentated. So again, the comfort of the patient was affected. It was a good system. We used it for about 10 years, but had significant limitations. And we moved to surface-guided treatments with LINRT. As you can see, we use the open mask. And the first question that we asked was, how does the surface-guided compare with the frame and other frameless techniques? And we have publications looking at the outcomes in terms of actuarial local control and actuarial overall survival. And you can see that framers surface-guided treatments are associated with very similar local control and 1 year overall survival compared with frame-based techniques. In the Beacon, we treated more than 2,500 patients intracranially since December 2007 when we started. Using LINRT, we have the largest series outside the US. We are a reference center for vision RT. Majority of the patients present with brain metastases, but we also treated trigeminal neuralgias, meningiomas, and vestibular schwannomas. We started with the LINAC-based SRS with variant trilogy TX with H definition MLCs and cones. We used initially the variant real-time optical guidance platform, as you can see it here. However, variant stopped the support in 2014, so we had to look at other solutions for these patients. So how did we choose? We had two choices. One was LINRT, the second one was BrainLab ExaTrack. So we looked at the costs, installation time, downtime time, which is important in very busy departments, and we looked also at patient comfort. For me, this was the most important part. So we chose in the end the LINRT. Why? The cost was about 3 times lower. The downtime time was half a day, comparing with 2 weeks. Again, this is important for very busy departments, so you don't stop patients' treatments. And for the patient comfort, we used the LINRT uses the open face mask, as you saw, comparing with a closed face mask. And this is again important for the comfort of the patient. It's not nice to have something in your face all the time. How we've done it, the Vision RT did a room survey about a month prior to the installation. The physicists in our department installed the mounting plates. The cameras were installed by the Vision RT engineers over the weekend. The physicists did the acceptance testing on Monday, and the patient was treated the first patient was treated in the same week. Again, this LINRT is completely integrated with Varian machines that we have. What we do, we use this Macromedics open face mask, as you can see here. What you have to remember, again, I come back to the importance of the region of interest definition. You have to make sure that you have enough face outside the mask for the definition of the ROI. And you need also the chin, make sure that the chin is down. And I will show you in the next slide why. The occipital part of the mask has to be deep enough to ensure the stability of the head. And you make sure by allowing only 2 fingers between the plate and the mask. Why the chin down is important? It is because you will have a position of the gantry where you are not going, one pod will be blocked by the gantry. So you'll have a restricted view of this region of interest and very little information, a lot of noise. So make sure when you simulate this patient that the chin is down and the mask is stable. The workflow, I'm not going to go into too many details. Again, the only thing which is different is the export to the LineRT. How we do it at the machine. So we set up the patients on the DICOM-RT surface. We acquire a cone beam CT. If the patient is stable, we match the cone beam CT. We apply the 4 degrees of freedom shifts, and we capture the reference image, as you can see it here. We review the cone beam CT, and we apply offline all the shifts required. If the rotations and rolls are less than 0.5, we proceed with the treatment, and we monitor continuously during the treatment. If we have rotations or rolls or pitches more than 0.5, we restart. Again, if the patient is not stable, you reposition the patient, but this means taking the patient off the bed and restarting from scratch, and then we restart the whole process. The therapists are monitoring very easily this screen and the surface of reference. It is very, very important to exclude the mask from the definition of the region of interest, exclude the cheeks, especially in patients who are puffy from the steroid use, and we have to use the frontal bones for the definition of the region of interest. And we've seen that false eyelashes, makeup, and brushy eyebrows is not a joke. This can impact on the accuracy of the noise and what the surface monitoring. So we tell all our patients, don't use makeup, don't use false eyelashes, and shave before the treatment. The limitations, obviously, they are limitations of the technique. And then as the previous speaker already said, we will have the 2 lateral cameras, which will be very blocked for a very short time during the cone beam CT acquisition, resulting in this noise. Will not capture any patient movement. So what we recommend is to record the patient position at the beginning and at the end of the cone beam CT. And obviously, because we are a department which is quite dynamic and we trust the data in the literature, but we still have to check it on our own, we looked at how stable is the open mask. And we looked at 78 fractions and we recorded the differences between before and after the application of the shift on cone beam CT. And we've seen that the magnitude of the translations and rotations is less than 0.3 centimeters and less than 0.5 degrees for the majority of the patients, which means that the patients are stable in the mask and they are also comfortable. Because don't forget that the patient who is not comfortable is going to move. We also looked at the cone beam CT versus AligneRT. Can AligneRT be used as the only tool for monitoring and controlling the process? So we've seen that the majority of the shifts in the vertical, longitudinal, and lateral directions are less than 2 millimeters, and the rotations, the majority are less than 0.5 degrees. We suggest that yes, it is a correlation. Could you please stop? It is a correlation between the cone beam CT and the AligneRT. However, the AligneRT does not replace the cone beam CTs. AligneRT is a surface-guided technology. You need to image the tumor. So the gold standard will remain for you the cone beam CT. SGRT is complementary in patient monitoring, initial setup, intra-fraction patient movement. I think that for me, this is the most important feature of this technology. Reduces the imaging dose and reduces the anesthetic needs. We looked, our physicists, they are very, very active. They looked at the position of the isocenter and versus the pitch. And what they've seen was that the cerebellum, so the posterior part of the brain, will be significantly impacted by pitch when it is more, for these locations being usually more than 0.5 degrees. And why it is important is because you can miss the target if you don't apply it. So you have to be aware of the existence of the pitch, which a line RT will give you, and you have to apply it, because otherwise, if you don't apply it, you can see here that your target is near the edge of the PTV. If you don't apply it, you'll miss the target. You miss the target, the efficacy of the treatment is 0. We've seen that the system is quite stable and flexible, so nowadays we are able to use it for treatment of the multiple metastases in a single arc. Again, for these patients, usually the isocenter is away for the treated area, so you have to monitor the rotations and apply them. And this is an example where if the rotation wouldn't have been applied, would have resulted in overdose of the optic nerve and blindness. This is a very interesting case where a line RT shows its adaptability and flexibility. It was a patient, a 52-year-old female, very claustrophobic, metastatic breast cancer, came with this large cerebellar mass. We initially planned for 24 grays in 3 fractions. She was unable to tolerate the open mask even. So what we decided to do was to use only the occipital part of the mask. We increased the margin to 5 millimeter. For the PTV, we usually use a margin of 1 millimeter. And we decided to use the real-time monitoring of the position of the patient. This is the screen that we used. And what we've seen is that for the entire duration of the treatment, the majority of the shifts are less than 2 millimeters. So the patient was very, very stable when using only the occipital part of the mask. A line RT was installed initially in September. Since then, we treated more than 800 patients using this technology for SRS. 98% of the patients completed successfully the treatment, and we maintain very similar tolerances to Varian optical guided platform that we used for the previous 10 years. Now, Greg and people who are in Bucharest know already how we use the SGRT for hypofractionated treatment and tattoo-less techniques. So I know that the tattoo-less technique is one of the biggest points for surface guidance, but while it is important, I think that you have to remember that these patients are going to survive longer than they used to. They are going to come for retreatment. So yes, tattoo-less techniques are nice, but they can be limited when you have a patient who comes for retreatment and you don't have the same system to reproduce the old plans. So how are you going to account for this? I don't think that we know yet. So hopefully everybody will have the same system so we can reproduce what we are doing. Hypofractionated treatments are, as I mentioned, require large dose per fraction. They are very conformal, longer treatment time. So again, potential for patient movement. It requires a very rigorous image review at the time, which means that it is again time consuming, so the patients can move during the analysis of the images. And we also have to remember that these are patients who there are other factors which are contributing to the patient motion, such as natural position, room temperature, and so on. The old system that we used to use, the block, the Varian RGSR block, does not have the patient motion functionality, so you need to retrack each time when the patient moves. What Line RT allowed us to do was to move to a non-RPM SABR program. We use it now for intrafraction monitoring for all sites, and not only for stereo, but also for 3D and IMRT treatments. Our therapies came from, I think, the Genesis in London, very excited about the tattoo-less technique for breast. So we decided, okay, let's use it for breast, but also for other sites. So what they looked at assessing the efficacy of Align RT as a surface guidance tool for setup, for monitoring the intrafraction motion with the tolerances of 0.3 centimeters and 3 degrees rotations, and to see if we can increase the safety when delivering the SABR doses. So they recorded the shifts indicated by Align RT following the setup, and the shifts indicated by the OBI system following the setup, and they checked for correlations. So what they've seen was that the absolute difference between the shifts required by the cone beam CT and the Align RT was small, again, less than 0.3 centimeters. So it is a very useful tool, the surface guidance, and the rotations were less than 1 degree in most of the patients. They also look at the difference between Align RT and the OBI for per sites, 15 patients with sternal or rib stereos. The majority of the shifts required are less than 5 centimeters. Very stable, very good, very flexible system. They looked at 55 patients treated for acute prostate MRT. Again, very stable and very small shifts required. Very useful tool to monitor these patients. And for 29 patients, again, we use usually 5 fractions. All the shifts are, again, very small, the majority, very small, less than 0.5 centimeter required. What they also found was that the heavy breathing caused rotational and translational differences, and this improved following the education on the definition of the region of interest. For the chest and abdomen, you'll find a vertical discrepancy when it is not enough lateral topography due to the immobilization. So you have to be aware how you define this ROI when you have a body fix. And this was a very, very interesting case where we shown how important it is to monitor intrafunctionally in real time. And this is where Align RT makes a huge, huge difference. This is the main reason that I would use it in every single patient. So this was a patient who, my patient, who was treated for metastasis in the sternum. Here she previously had chest wall irradiation. She came for retreatment, 18 grades in single fraction to the CTV, and we were planning to give an SIB 22 grade single fraction. We used the Align RT for monitoring the patient, and during the image analysis, so before even the treatment started, Align RT picked up motion. They re-imaged the patient KV and cone beam CT, and they've seen that the patient indeed moved. If we wouldn't have had the Align RT, we wouldn't have seen this motion, and the physics team reproduced what would have happened if we wouldn't have seen this motion. So this is what it should have happened. 24, 22 grades here. This is what we would have given if we wouldn't have seen the motion. So we would have missed the target. So it is why I'm saying the intrafraction monitoring is probably the most significant feature that this system allows us to have. And very shortly, because Gabi is going to speak about this, for the breast and chest wall irradiation, initially we were using the RGSR system as a surrogate for the lung filling. Again, this does not track the patient motion, and you'll have to retrack each time when the patient moves, you'll have to retrack the block. So it's not a real-time monitoring of the patient motion. In 2010, we introduced the Align RT, which tracks the breast tissue. As you've seen, it's highly accurate for free breathing and deep inspiration breath hold. And it is important for these breast patients, especially like everybody who treats breast knows that in the first 5 days of the treatment, they are quite anxious. They will bend, they will move. Align RT allows to identify this bending of the back. So this is important. It will show you that the patient moves. And in August, we have the Align RT Advance. Again, very, very, very easy for the therapist to monitor if the patient moves or not. They absolutely adore it, not only for the setup, but also for monitoring during the treatment. We compare the RPM with the SGRT. Why? Because I was skeptical about the tattoos. So I was like, no, we don't implement it until we check it. So what they've done, we looked at 10 patients treated in the previous 10 years, and we audited the first 10 patients treated with the SGRT, and they compared the magnitude of the shifts, the total treatment time, and the number of the setups required, especially when supraclavicular fields are used. And we know that it's very difficult, in fact, to set up appropriately the patients every time, especially when three fields techniques are used. So what they've seen, so what you want to see here, so you have RPM in blue, SGRT in orange, and in green at 1 year reanalysis of the shifts. So you want to have these curves as close as you can from zero, and you can see from the curves that SGRT performs much better than the RPM. Okay, the curve is much closer to zero, and this applies for the magnitude of the shifts in the vertical, lateral, or longitudinal directions. This is very, very, very important because the treatment time in average is reduced from 15 minutes per patient with RPM to about 10 minutes per patient when SGRT is used. And this is extremely important, especially in busy departments, and we all know that, the impact of the treatment time, especially when you have a busy practice. For the additional setup required, like if you have a patient treated with 3 fields technique, usually the SGRT will decrease the number of setups required, the number of imaging required for the patient setup. This does not change for the patients treated with 2 fields techniques. And this is an example where you can see the advantage of the postural video in real time. So this patient was treated for day 1 with no postural video. The MV image shows the arm in the field. A few days later, day 3, she was treating using the postural video, and you can see the arm is out of the field. This helped the therapists to set up the patients much, much nicer. What we've seen as the top benefits from Align RT were improved efficiency with the reduction of the patient localization time, and this is across all sites where we use it. Improved accuracy with the reduction of the shifts magnitudes. This is also across all sites that we looked at. The consistency of the breath hold was also improved. We improved the safety standards by using the real-time intrafraction monitoring. And again, for me, this is the most important feature of the system. And the staff are also much happier because it is a reduction of the patient manipulation time, reduction of the wrist and back pain that the therapists are reporting and so on. So for us, these are the 5 top benefits from using this system, not only for hypofractionated treatments, but for regular radiation treatments. And with this, I would like to thank you all for attention. I would like to, my son and my fiance helped me go through these crazy times mentally, and the staff from the radiotherapy team, especially Darina, who is a physicist, Marie and Kate are the therapists. I have the luck to work with a very, very active and impressive team. And thank you again for inviting me to present.
Thank you, Professor. It was an excellent presentation with a lot of practical applications. And I would like to invite our next presenter, who is Mr. Nadir Küçük from Turkey. He's chief physicist at the Anadolu Hospital in Turkey. And as you know, in Turkey, there are a lot of radiotherapy centers with modern equipment. And some of us were also learning from Turkish radiotherapy books. So we are happy to have you here.
Thank you very much. First of all, before beginning, I would like to thank you. I would like to say two thank you. The first one is to organization committee. So I would like to thank you to SGRT community, Vision RT, and the Oncosystem. They invite me here. It's a great pleasure and great honor for me to present my presentation here. And the second one is the oncology team in the Cluj. They invite me yesterday in the hospital. I have a great time in the hospital, and also we have a great dinner yesterday night. So thank you very much for the dinner yesterday night. So thank you very much. So what will I do? My two presentation. There is a two presentation before. I'm just checking, and some people are bored because there's a lunch in the outside, and some of my slides are covered by the previous presenters. So I would like to give you brief information and what we are doing in the clinic. So let's start from the beginning. So my presentation is, I would like to tell you basis of the SGRT, which is covered by directly. I would like to give some small words about this, and then I will give you a quick overview of the Vision RT system, and I'll tell you about the Vision RT workflow and what we are doing in our department. So let's start from the Anadolu group. So I'm working in one of the big hospitals in Istanbul, in Turkey. So we have 4 radiation oncologists, 4 physicists, 2 dosimetrists, we have 10 therapists, and 3 nurses. So all radiation therapy except brachytherapy we have, and we have well known in the country as a radiosurgery hospital. So lots of people refer to their radiosurgery patient to us. The hospital is really quite standalone hospital, established in 2005. We have an affiliation with the Johns Hopkins, and we have mainly targeted to the oncology treatments. So we have really many patients from the abroad. So we have a very strong international department in the hospital. So we have some, oncology, we have some members in the oncology clubs or some organizations. So, and the team that we are working in the hospital is met in the hospital in 2017. So what we have in the department, we have different type of machine. We have Varian Edge system. The SGRT system is installed in the Varian Edge system, and we have a CyberNav M6 model CyberNav. So we have 2 CyberNav before we upgraded with the new one, and we have a Radixact system in the department. CyberNav and the Radixact have operated by the precision system. So we have only one treatment planning system. So we operated the both system with the precision and the IDMS. And also we have an intraoperative radiation therapy in the department. So let's start from the SGRT again. So just a little bit brief information about that. What is the SGRT? When we talk about the SGRT, we know that the system generating a 3D patient surface in real time, the important one, the real time. Okay, and the system uses the combination of the projectors and one or sometimes several camera to create a 3D surface. In the system or in the treatment room, you can create a reference surface related to the treatment is a center position, and these are used for calculate the necessary correction for the patient position in 6D. Okay, and enabling image guidance for radiation therapy. Initial motivation for the SGRT is, I think, for the setup or replace the laser or skin markers for patient positioning. But now, the Oracle says that now it's now uses through the entire all radiation workflow. So why we are using SGRT? So in different step we are using SGRT. The first step, I think, for the patient positioning. So the treatment times are really decreased, and the imaging dose are really decreased if you are using a SGRT system in your department. In the treatment, especially for the safety part, very important, because if you are using a SGRT, you will add additional level of the safety in your treatment. And also, you can track and see the online surface deviation during the treatment. And the last thing, I think, if you are doing a gated treatment, like such as DIBH or swallow breath hold, you can easily do with your SGRT system. You don't need very expensive cameras or some hardwares from the companies, from the machine companies. So you can easily get or do this kind of treatment with SGRT system. And also one of the important things, and nobody think about that, if you are doing is DIBH or breath holds, sometimes the stability of the breath holds is very important. The patient is doing a breath hold, but the stability is the breath hold is very important. So with SGRT system, you can track and see the stability of the breath hold technique. So normally what we are doing, whole you are a radiation oncology department, I think, and what you are doing in your department, so you are using a laser, I think, for patient positioning, and then you are doing a IGRT, and then you are doing a treatment, I think, during your whole setups. So if you are using a SGRT, these are changed. So you are using a SGRT software for setup, which is very easy. The previous speakers will tell you more about this. So, and also in the treatment, you can track the patient very, very precisely. And you can track patient surface, you can track patient movement, which is very important. But the important thing is in the IGRT part. IGRT is still same, which means that as SGRT is not an IGRT method. Don't forget this. And it doesn't replace the CBCT. Still, you need to get the CBCT because we need the information from the internal. So you need to get the CBCT for the patient. We still need 3D imaging methods, and SGRT is not fully integrated with the imaging modalities. You can use the SGRT system during the IGRT, but it's something like a manual. So for patient positioning, of course, we are getting it 3D information from the surface. And also, if you are treating a skin tumor or something like that, it's very easy to track the surface with the SGRT system. So, which is more accurate positioning compared to the 3D point laser system. And you can reduce the number of the imaging because you can easily, align the patient according to the postural camera and some other, softwares in the SGRT system. If you are treating a deeper tumors, such as lung or some other tumors, there is no direct correlation between the surface and the tumor movement inside. So which means that you need a daily imaging, still mandatory, and SGRT can reduce the time required for image registration, and it prevents you to need the multiple imaging. You don't need to get lots of imaging during the setup if you are using a SGRT system. So this is our H system. There's a 3 camera here. The previous speakers are already mentioned what they are, and there is a 1 projection here. So this 3 camera produce a 3D surface reconstruction in the surface. So the projection, if you are turning on to the system, you will see some red lights on the patient, which means that the system creating a 3D surface, and you will match this 3D surface which is coming from the treatment planning system. So what we are doing in our department in the workflow. So after we finish the plan, we sent to we have a DICOM interface between the SGRT system and the variant system. So we sent the structures first, which means the body, because the system needs the body structure, and the system also needs the plan because the system wants to know the isocenter, where the isocenter is. So there's 2 information very important. So we are sending from the treatment planning system to these two information, and then the system creating a reference surface, and then we are creating a ROI. I will tell you what the ROI is, but the system used this ROI for fusion, which means that the real surface and the treatment planning surface, we will match it, and the match will be in this area, which is called ROI. Okay, and then the therapists go in and doing a setup with the use of by using postural camera. And during the setup, we see the patient here. We align patient because there's another monitor in the room. So the patient and the therapist see the patient position and align the patient in the treatment room. and then we get the IGRT. If you want, you can check the SST in the system, because we have a SST value in the treatment planning system, and then also the system give you, SGRT system give you SST values, so you can check the SST or some other plan parameters, and then you can start the treatment with a tolerance. So before IGRT, what we are doing in Anadolu Medical Center, so we are doing initial setup with using as you do a positioning with, we are using a laser system, and then before treatment we do a 2D or 3D registration. We are using a CBCT sometimes to get the shift, and maybe we do the second CBCT, because especially for the lung SBRT, we are getting a second CBCT after the first CBCT, because if there's a very large deviation between the first setup, the second one, the patient sometimes move. That's why we are getting a second CBCT to be sure that everything is okay or not. And during the treatment, we are using RGSG system, which is RPM system from the cube system from the variant. So we control the patient during the treatment with the RGSG system, and we will get another post-CBCT after the treatment. This is the workflow before the Vision RT integrated in our department. And what happened now? So for the setup, we didn't use any laser system now. We are only using a procedural video, which is very easy and very user-friendly for the therapist. But about the before treatment, we never use 2D or 3D QV imaging now. We only get the first CBCT, and again, we would like to be sure that the patient is not moved during this imaging time. So we will get another CBCT again. And during the treatment, we use two control systems. Still, RGSG or RPM is still open, and also we use a surface tracking system. So the Vision RT still in the system. So we do two control systems on the patient. And as you know, we use the post CBCT after the lung SPRT, but now we are not using a post CBCT because Vision RT or SGRT system was already tracked during the whole process. So what kind of patient we treat? We have a lot of SRS-SPRT patient. We are mainly using for the SRS-SPRT patient because the accuracy and our PT margin are very narrow. That's why we would like to be sure that the patient is not moved during the treatment. And also we are using in the conventional treatment such as left breast, thoracic tumors, or some extremity or some sarcomas, we are using a Vision RT system. So this is our experience. So I'm sure that lots of people are not using a SGRT system here. And this is our idea after we get to the SGRT system. So first of all, forget the patient setup, before. So the patient setup is completely changed because you are doing according to playing with the video, So you are using a video for patient setup, and many new things waiting you in the patient setup, which means that different type of setup you need if you are using the SGRT system. And I think very important thing, education is whole clinic is very important, but I think the therapist is very important. You should, educate your RTTs, and this is very important. Okay, one of the important factor in the system is that the system should be user friendly, and therapists know very well about the system. And we used to think that we are treating the robots before. So just before the SGRT, we are very relaxed because we do the IGRT, we do very good setup, and then the patient is, start the treatment. We are doing a beam on the patient is, receiving a radiation. During this time, we are talking to each other. Sometimes we are checking to the camera from face, but we are not doing anything. So which means that we are thinking that the patient is robot, patient is not moving. But what I understand that the patient is also moving a lot during the treatment. And this is very stressful thing for us because we saw now that the patient is moving and the SGRT system avoids you, and tell you that the patient is moving. This is very stressful for the beginning, but it relaxes you because you understand that the patient is moving and you can have some tools to, change the patient position or get another CBCT or some other things. And also another thing, you can create a mini reference capture during treatment. So don't forget that if the patient is moved, of course, the surface guided systems tell you that the patient is moved. So what you can do, you can get another IGRT, or many times you can create another reference image to track the patient. So no stress, but be careful. This is very important part. And the last thing for the physicist, so it may be appreciated for medical physicists. It would be good, I think, for the medical physicists to join to the treatments, especially for the beginning, because sometimes if you are only the therapist, if you are only trusted the therapist, of course they are doing a great job, but sometimes they need some supports. So the physicist should be spend some time, especially for the beginning, at the very beginning of the installation. So let's go to the driving ROI. I think ROI is a very important part of the system because we are doing a fusion with the ROI, okay? So the system displays the entire surface, of course. You can create a very entire surface, but we are creating a ROIs, okay, which is used for matching, okay? If the cameras cannot see the ROI because the gantry is moving, so that's why sometimes the cameras are blocked, okay? Or if the ROI is covered by the immobilization, sometimes immobilization systems are, covered and the camera cannot see the patient. And at that time, a correct match cannot be made. So we should be very careful for contouring or driving to the ROI. So look at this one. So this is one of the patients. This is, breast case. So there's a 3 camera here. So you can use maybe these two cameras because we are using a field on field technique for this patient. And when you look at the gantry angles something like this. And when you are in this gantry angle, it's very difficult sometimes to track the patient with this camera. So what we are using here, of course, the left camera, it will be very useful to track the patient here. And think about another case, for example, the VMAT case. So there are a lot of gantry angle here, and you have sometimes the camera blocked to one of them. But be careful that you cannot see anything here. But still, there is a right camera here, and right camera can track the patient very, very easily. So the multiple camera is really very important in the SGRT system. But the important thing is that, again, ROI. So you should get the patient, especially the right camera needs some information. And if you are not contouring this part, the camera cannot get information from the right side of the patient, which means that, we should, when we are creating a ROI, of course, we need to think about the techniques or gantry position, not on the treatment sides. So of course, when we are contouring to the ROI, we should think that if it's a breadth, there's some way to contour it, but we should think also what technique we are using or what kind of gantry position we have in the plan, which is a very important part of the system. So the medical physicists and therapists should know very well about how to drive the ROI. So sometimes the patients are moved, of course, especially for the lung tumors, you will see that the patient is moved. So which surface is tracked, because there's a multiple surface, and one of them should be tracked by the system. So look this one. So the system gets lots of images. So you can choose one of them, which one is the middle. Sometimes, lots of times, we are choosing this middle one, which is very important one, and you can track the patient surface according to these values. If you contour ROI with the moving part, the system cannot track the patient during the treatment. So you have a lot of trouble during the treatment, which means that you should be very careful to track, contour which part of the body you will contour it, and also you should be very careful which surface you will take in account during the treatment. So this is one of the cases. This is left breast cases, okay? So we are not treating patients anymore with the normal breathing system. We are using a DIBH, breath hold techniques, and we are using a field on field technique. But we should tell the patient that the patient should breathe in slowly through your nose, which means that the patient use nose for breathing, which is very important. And the other one is that we are telling the patient that feel your chest. Okay, this is very also important, not your belly, because sometimes the patient is moved with their belly, okay, which is very, difficult to track during the treatment. And another one is that don't arc your back. Sometimes when you tell the patient that breath hold, the patient is breath not from the nose. The patient see their sickness and they are trying to do, like something like this. Not for breathing. The patient try to move his body to reach this level. So we should be very careful that the patient is not, arc their back. So this is our treatment planning. This is for the left breast. So you can, of course, we have two options, as I told you before. We have an RTC system. You can use it. It's mainly installed in last week. That's why, so just before we are using the RGSG system for now. Also, you can use the variant camera system, which is called RGSG or RPM system. So the patients see what level of the, what kind of level or how much level the patient will breathe. So let's look at here, the patient, we will get the gated CBCT from the patient. You see the patient is really very good, breath hold. And then, the patient is go outside here and the beam is off. But if you would like to do it with SGRT with gated CBCT, if you want to use SGRT system, the gated CBCT can be obtained with SGRT, of course. You can do the same thing like the Avarian do, but the problem is that this procedure is still manual, so you should be very careful. And the lack of the integration between the SGRT and CBCT may be a major problem, especially in the DIBH patients. So one of the big problem I think SGRT system is that there's a lack of integration between, especially for the IGRT part. So it is necessary to recreate a reference surface for each table position, which is another important part, and often blocked due to the open CBCT arms. When the CBCT arms open, lots of times the cameras are blocked from these arms. But I know that the companies are working on this issue. But the good news for the variant users that RGSG and the Vision RT can be used simultaneously, which is our development protocol at the same time. In this time, we are using at the same time both Varian and Vision RT system together to see if there is any problem or not. So this is left breast ROI. So what we are doing here, we are contouring the breast tissue and chest wall. We have a stable surface, of course. We need a stable surface, of course. So we are trying to contour the lateral aspect part of the breast tissue, which is very important to see to get the vertical information from the patient. So we have two simulation. One of them is free breathing CT. The other one is the DIBH CT. So we have two planning CT from the patient. We are doing a plan on the DIBH CT. We are sending both free breathing CT and the DIBH CT surface to the machine. And the therapist is doing an initial setup with using a free breathing CT because, which is more, makes sense to do all the setup with the free breathing CT. But we are using a DIBH CT for the treatment. So this is some example of our left breast cases. So, you see that the patient is, is not breathing now. When the patient is breath hold, the system turning to the red, turning to the green and getting into this level. So these are our DIBH and free breathing surface, prescription in the software. So let's go a little bit, just on 5 minutes, go and concentrate on the SRS-SBRT cases. Of course, the system have lots of, QA protocol. If you want to do this kind of very sensitive treatment, which means you should do some, QA. And the system have a cube, and also the system have a plate, and you should do your camera calibration according to this information. We are using an open mask for the patients, you see here. So the laterals are very open here, and at least 2 centimeters space from the eyebrow. And also we have a very rigid chin position on the patient. If you want to treat the patient with the hyperac is one of the variant technique which is used lots of non-coplanar beam. So you can manage this kind of treatments with using a SGRT system. So if there is a non-coplanar beams, RGSG or the cube is not working. This is clear. But Vision RT works very well for this because you can, as you see here, this is the patient have a non-coplanar beam here, and you see that you can create a non-coplanar, surface from the Vision RT system, which gives you a very safe, treatment during treatment for the SRS-SBRT treatments. So there are some studies aiming that they are trying to remove the whole mask partially or totally. So maybe after 5 years, when we are talking about the SGRT system here, maybe the people are not using a mask because SGRT system will be cover all the things, I think. But still, there are some, experimental studies trying to do some study and try to find some solution or some results to remove if it is feasible to remove the mask or still we need a mask. This is a big question mark at the moment. In the lung SBRT with the IBH, so of course what we are doing here, we are getting the IGRT, and then we are trying to, we are trying to tell the patient that, the level of the RGRT system we are showing, and we are training the patient according to this level. And then we are getting the signal from the software in the variant system, and we are trying to track the patient here. But sometimes it works, but sometimes SGRT is not work. This is what happened in some treatment, because SGRT is very, very sensitive, and vision RT is very sensitive. And if the patient is moved something like this when they are doing it DIBH, the variant cameras cannot detect this. But SGRT cameras detect and said that the patient is moved. The patient is not breath. Patient is moved that's why the patient surface are changes. So this is one of the good examples for the patient, and we are very surprised to see that sometimes the variant signals, variant cameras are not see and continue their treatment, still, SGRT giving us some error on the patient. And when we check the patient with the cameras, the patient is really, when they are breathing, they are not breathing, they are moving to their surface. So we recognize that SGRT is doing a very great job in this kind of treatments. So this is our lung case. As you see here, during the setup, you can use a postural camera here, and then we get the CBCT, and we get the reference capture, which means that the real treatment position is that. And then we have some, of course, tolerance values on the SGRT system, and then we track the patient according to this number. So if the patient is moved, or if the breathing is unexpected than we are expecting, and these levels are turning to the red, and the system is automatically stopped. Radiation is automatically stopped. So last two slides, in my country at least, there are some discussion if it is one camera is okay, or we need a 3 camera, because if some companies want to sell one camera because cheaper than the 3 camera. Okay, so the discussion, I think this is a good discussion, but I think the science say everything, which means that if you have one camera, okay, if you have one of the camera here, of course you can do some job. You see here, so we use, normally the systems use 3 camera here, and according to this 3 camera, this is a 3D surface reconstruction here. But if you are using only one camera, like a central camera, okay, the companies are give you the central camera. Of course, you have some information, but your informations are very lack. So which means that lack of information from the sides may not adequate to detect movements, especially in the vertical plane. So if you are buying a one camera, probably you will not track to the vertical plane of the patient. So thank you very much.
Thank you. So we just came to the session of questions. So if you have questions, please do not be shy and ask them. You're gonna have also a demo presentation at the end, and maybe it will be easier. If there are no questions, we will have a short coffee break. At this point is 14:30, and 3 o'clock would be fine to be back. Okay, so at 3 o'clock, see you for the next session.
problem that it's in English, or do you feel more comfortable if we're going to talk in Romania, or maybe if you would like to ask questions in Romanian, feel free. So, Romanian is fine? Ok. Îmi face plăcere să fim prezenți fizic astăzi aici, ca să reluăm întâlnirile științifice live. Sperăm să dureze forever de acum încolo, să nu mai avem valuri care să ne arunce iar în online. Pentru cei care, în fine, suntem o comunitate relativ mică de radioterapie și o țară mică, dar pentru cei cu care n-am avut plăcerea să mă întâlnesc, sunt profesor de radioterapie la Universitatea Iuliu Hațegaru din Cluj și directorul medical pe Ametist România. Și am plăcerea să lucrez într-un spital mic, dar care face parte dintr-un chain, dintr-un lanț foarte mare, care operează în Europa, în Marea Britanie, Franța, Italia, Austria, Polonia, România și Germania din această lună. Deci, în caz că, în fine, doriți să mergeți să vizitați centre de ametist din Europa și, bineînțeles, sunteți bineveniți la cel din Cluj, ca să vedeți inclusiv acest Align-RT, sistem pe care avem privilegiul să-l folosim de 3 ani deja. Câteva slide-uri despre cât de importantă e radioterapia în cancerul de sân, dacă mai este nevoie să spunem acest lucru. O folosim la marea majoritate a pacienților, ca să nu zic aproape toți, fie în situație de tratament după chirurgie conservativă, fie că vorbim de in situ sau invaziv, și, de asemenea, în multe din cazurile după mastectomie. Dar, evident, că asistăm în paralel la o îmbunătățire a tratamentelor sistemice care reușesc să prelungească supraviețuirea acestor pacienți, dar care au și ele o toxicitate cardiacă. Și vorba tocmai de această balanță între ce facem bine și ce tratamentele noastre au ca și iatrogenitate, în particular cardiacă, pentru că aici aduce Deep Inspiration, Breath Hold un plus, dar nu numai. Și în partea de plămâni și așa mai departe. Știți că îmbunătățește controlul local, locoregional și, să zicem, analiza și meta-analize pe perioade foarte îndelungate au demonstrat că radioterapia chiar îmbunătățește supraviețuirea în cancerul mamar. Nu doar cea specifică, deci cea legată de decesele strict oncologice, ci și cea globală. Și o să vedeți că între cea specifică și cea globală, cum probabil știți deja, există o diferență, în sensul că uneori toxicitatea tratamentului scade din diferența mai mare în supraviețuire specifică, pentru că supraviețuirea globală, de exemplu, din decese de tip infarct miocardic, să contribuie la această micșorare a diferenței. Pentru carcinomul in situ, cu atât mai mult toxicitatea de sân, cu atât mai toxicitatea radioterapiei are relevanță, cu cât nu crește supraviețuirea. Deci, în in situ, radioterapia adjuvantă după tratament conservator, evident, scade cu un factor 2 rata recidivelor locale, dar fără beneficiu în supraviețuire. Pentru invaziv, fie că vorbim de breast conserving therapy, surgery sau de mastectomie, știm că razele sunt într-o doză, hai să zicem, 50 de grei echivalentă. Nu intru în detalii de hipofracționare acum, dar știm de asemenea că vârsta este un factor de prognostic și pacientele sub 50 de ani beneficiază de un boost, care poate fi administrat integrat, secvențial. Nici aceste detalii tehnice nu le vom discuta. Deci, cu alte cuvinte, dăm chiar o doză mai mare de iradiere decât am dat în in situ, care riscă să se repercute asupra inimii. Vedeți, e o rată cam de 3, un factor cam de 3 între cu boost versus fără boost în termen de recidivă locală. Și această diferență, pe termen lung, se traduce într-un beneficiu în supraviețuire. Deci, vedeți, curbele se distanțează la 10 ani, 10% diferență, la 20 de ani, 20% în termen de recidivă strict locală, deci numai în sân. Dacă analizăm recidivele locoregionale, vedeți că diferența este totuși considerabilă, dar în termen de supraviețuire specifică avem un beneficiu de 8% la 20 de ani și acesta se micșorează la 5% în supraviețuire globală. Și regula aceasta aproximativă de 4:1, deci dacă ai, să spunem, între 15 și 20% diferență în controlul locoregional, te poți aștepta ca down the road să ai un beneficiu de 4 ori mai puțin în procente în supraviețuire globală, 5%. Da, dar atunci când diferența e mică dintre radioterapie și absența ei, trialul Breast International Group, care pe subgrupul T1, T2, N1, deci 1-3 lymph nodes pozitivi, 4%, dacă împarți la 4, devine sub 1% beneficiu în supraviețuire. Deci, chiar dacă regula matematică se păstrează, relevanța statistică și clinică se pierde. Deci sunt, ceea ce vreau eu să vă spun, unele subgrupuri de pacienți care, de fapt, n-au o îmbunătățire a supraviețuirii și în acest context trebuie să fim foarte atenți la ce riscăm să le facem rău. Această publicație din 2013 a cuprins paciente tratate între 58 și 2001 în Danemarca și Suedia. Sigur, vă zice dumneavoastră, e o radioterapie rudimentară și nu putem compara cu cea din ziua de azi. E adevărat, da. Ideea era că există o corelație totuși liniară, între doza medie în inimă și morbiditatea și mortalitatea care poate să se translateze într-o diferență de mortalitate cardiacă. Studiile pe radioterapie, să zicem, mai modernă, nu au validat o supramortalitate cardiacă în cancerul de sân, dar conceptul care vreau să vi-l supun atenție este această creștere a evenimentelor coronare majore, care e infarct în principal, cu fiecare creștere în doza medie a inimii, 7,4% per grey, crește morbiditatea cardiacă. Irelevant. Și deși știm acest lucru, constatăm cu surprindere că la nivelul comunității medicale, trialurile actuale, care sunt ongoing, nu au ca și endpoint toxicitatea cardiacă, în niciun fel. Bineînțeles, secondary endpoint, că ne interesează întotdeauna first ce facem bine. Și era o publicație recentă, cu o lună în urmă, care ridica acest semn de întrebare, oare de ce nu le avem? Când știm că există acest risc de toxicitate cardiacă, poate fiindcă suntem așa de mulțumiți de radioterapia noastră că nu ne mai pasă sau nu credem că are relevanță clinică. Well, nu e așa de sigur, pentru că dacă te uiți la imagistică funcțională și măsori rata de perfuzie cardiacă, dacă utilizezi sisteme din acestea de control a respirației, și acum ne ducem înspre acest deep inspiration breath hold, constați că diferența e uriașă, de 27% versus 0% în defecte de perfuzie cardiacă, dacă utilizezi deep inspiration breath hold pentru cancerele mamare stângi. Sunt studii care au subîmpărțit structurile cardiace în a încerca a face un podium care e mai relevantă, care e mai puțin relevantă. Ambii ventriculi sunt în bătaia fasciculelor noastre când iradiem pe stânga, că e dreptul, că e stângul, și mai ales această arteră interventriculară anterioară. Este important să înțelegem că este structura de care probabilitatea apariției unui infarct depinde cel mai mult, dar nu numai la nivel de artere se pune problema, O să vedeți în prezentarea următoare când iradiem limfoame, care sigur că sunt în mediastin, este mult mai aproape de inimă, inclusiv afectarea valvulară are relevanță, deci valvele cardiace. Aceștia sunt printre primii noștri pacienți când am trecut la tehnica VMAT, un singur izocentru, locoregională, deci inclusiv cu ganglionii mamari interni supraclaviculari, și fizicienii noștri aveau dificultăți să ne ofere un plan care să respecte toate constrângerile de doză, în particular față de inimă și plămân. Scopul nostru fiind să fie un mean dose la inimă sub 5 gray și așa mai departe vis-a-vis de constrângere pentru, o să vi le arăt imediat, pentru plămâni. Le lua câteva zile și eram adesea nevoiți să facem diverse compromisuri pentru a păstra raportul dintre bine și rău cât mai, după știința noastră și după priceperea noastră, cât mai în favoarea pacientului. Și lucrurile deveneau și mai complicate când aveam pacienții din acestea cu iradiere bilaterală, în care ne-ar fi plăcut ca inima să fie un pic mai departe de peretele toracic decât era în realitate și chiar și ficatul pe dreapta ne-ar fi plăcut să fie un pic mai departe. Sigur, veți zice, da, puteam să le facem în alte tehnici, în pronație, cu sânul, să zicem, ieșind, degajându-se de pe planul cutiei toracice și, vedeți, chiar dacă inima rămâne în continuare la fel de lipită de perete toracic, ca să acoperi limitele, extremitățile, poți să-ți permiți să fii mai tangent la inimă și nu să ai overlapping-ul respectiv care era necesar ca să acoperi, să zicem, marginea internă și externă a sânului. Sau putem să facem brahiterapie, cel puțin ca boost. Nu voi vorbi aici despre adjuvant partial breast irradiation, care este un contingent mic în ansamblu din cohorta de paciente care beneficiază de aceste. Așa că am fost fericiți când a existat această, zicem, tehnică de deep inspiration breath hold, în care în inspir profund, plămânii se expansionează și se interpune, evident, această lamă de țesut pulmonar în fața inimii. Inima este îndepărtată, verticalizată și o încasează mult mai puțin. Vedeți, aici ai 1,5 centimetru, 2, poate aici nu mai ai deloc. Și acest grafic sintetizează toate tehnicile de active breathing control, deci nu numai deep inspiration, dar oricum ar fi cele care cu active breath control au o mean dose și toți parametrii relevanți V5, V10, V20, V40 în favoarea acestei inspirații profunde din punct de vedere a cordului. Dacă pui și izodozele, vedeți că aveți o includere a interventriculare anterioare, aici chiar și în izodoze de 95%, pe când totul devine mult mai departe dacă reușim ca pacienta să iradiem sincronizat cu respirația în faze inspiratorii profunde. Și dacă înregistrăm și coregistrăm în inspir și în toate fracțiunile respirației, cam așa ceva obținem. Deci vedeți plămânii cât sunt de departe în inspir profund și inima cum în poziție, să spunem, intermediară, dacă vreți, se verticalizează și se pune pe linia mediană, îndepărtându-se de peretele toracic. Ați văzut deja toate avantajele în prezentările generale și ale antevorbitorilor mei. Deci, este vorba de o creștere a siguranței, în esență, îți permite să reduci CTV to PTV, dozimetria se îmbunătățește nu numai pentru organele la risc și cu precădere pentru inimă, dar chiar și coverage-ul pentru PTV și mai ales această abilitate de a verifica mobilitatea în timpul radioterapiei, intrafracțiune, că celelalte, într-un fel sau altul, cu cone beam CT sau alte image-guided radiotherapy, care nu renunțăm la ele, deci această surface-guided radiotherapy este complementară CBCT și nu o substituie. Deci nu vezi decât suprafața, nu vezi în interior poziția efectivă a organului. Și s-a acumulat deja o mulțime de literatură care susține această tehnică în foarte multe indicații. O să vedeți câteva mai atipice în prezentarea Renatei, dar se pot extinde. Utilitatea ei este dovedită, practic în toate cazurile te ajută să poziționezi mai bine pacientul așa cum spunea Alina Mihai în prezentarea ei, că ei o utilizează la toți pacienții, dacă am înțeles corect. Nu numai stereo sau sân. Deja ne apropiem de 300 de pacienți, deci sigur nu ne comparăm cu câteva sute față de câteva mii cât are centrul din Beacon, dar e rutină. În ziua de azi avem, 10 paciente în fiecare zi care fac Deep Inspiration Breath Hold. Plus altele sau alții la care utilizăm sistemul fără a fi în registrul acesta de Deep Inspiration. Acesta este flowchart-ul pe care funcționăm cu o etapă preliminară de informare a pacienților, semnează un consimțământ informat. Este această simulare în free breathing și în deep inspiration, deci ai nevoie de 2 achiziții. Da? Deci faci achiziția clasică și după achiziția în deep inspiration. Gândiți-vă dacă îl veți instala pe o singură mașină, dacă mașina respectivă e în pană, ar trebui să aveți un plan și de free breathing, măcar în ziua în care nu funcționează aparatul respectiv, dacă poți să îl muți pacientul, să muți pacienta pe altă mașină, cu sigur respectările criteriilor de doză și partea de setup, monitorizarea audio-video și executarea tratamentului, cu importanța deja subliniată a alegerii regiunii de interes, să coborâm suficient de posterior aici, dar fără să luăm brațul și cu siguranță orice, device, inclusiv lanțuri sau halate care riscă să se interpună în bătaia camerelor care sunt pe tavan, sunt îndepărtate. După aceea, sigur că pacientul îi se arată, nu e nevoie să ai neapărat Line RT și la CT. Pacientul trebuie să înțeleagă principiul de funcționare și le putem arăta filme și după aceea să-i ducem în sala de tratament și le explicăm cum e cu monitorizarea aceasta video, contactul permanent care îl are cu noi pentru a îi instrui ce să facă și obiectivul final este ca să fie culoarea verde în ceea ce văd ei deasupra capului, o să vă arăt imediat, și ecranul nostru să arate fără depășirea plus minus 3 sunt setate în general. Da? Deci când e până în 2,5, cum v-a arătat și colegul din Turcia, it's ok, all good. Toate în 6 grade de libertate. Pacientul are ca obiectiv să vadă această linie verde în mijlocul liniei albe, deci cumva acesta este device-ul care îl vede deasupra ochilor, adică aici. Trebuie să avem răbdare, dar odată ce pacientul a înțeles corect ce trebuie să facă, e o bună complianță și să înțeleagă că nu poartă răspunderea dacă s-a mișcat involuntar și a încasat radioterapia sau fracțiunea respectivă aiurea, nu-i vina lui, mașina se oprește. Deci el trebuie să aibă sentimentul siguranței. Mașina se oprește automat dacă a ieșit din scala presetată. Și pacienții în free breathing facem o primă excursie, o primă verificare și dacă ni se confirmă că a înțeles ce trebuie să facă și vedem că reușește să țină, noi am setat la 20 de secunde, perioada minimă în care reușește să țină respirația. Mă asigur că dacă ești în stereotaxie vei avea doze mult mai mari pe fracțiune și dacă iradiezi numai în ferestre de bucăți de 20 de secunde și trebuie să-i dai 18 grei, de exemplu, pentru un cancer pulmonar, early lung cancer, undeva in the middle, și vrem să-i dăm 3 ori 18 grei, 18 grei respective îi dăm foarte multe ferestre Deci trebuie să te gândești, chiar dacă la început pacientul pare să coopereze, cât de relevantă și faptic realizabilă este această tehnică ulterior. Facem ca un BIM-CT, deci nu substituim Align RT-ul cu CBCT, facem modificările necesare din couch și după aceea another surface guidance, adică facem o achiziție nouă cu suprafața, în poziția corectată. Și, sigur, obiectivul este să fie sub 0,5 aici și sub 3, plus minus 3 în fiecare parte, trebuie să fie all green. De îndată ce depășește, mașina se oprește, înțelege. Nu știu dacă merge acest film.
Ușurel expirați,
Este
după
colegul
care
nostru
inspirați,
Rareș,
încet.
Bujor, ultra calm.
Este Ok, bun, țineți, vă rog.
O să auziți în sală?
Expirați încet, vă rog.
Deci asta a fost dummy run-ul, adică prima încercare să vedem dacă pacienta într-adevăr a înțeles și colaborează și acum începe efectiv tratamentul.
Inspirați, vă rog.
O să vedeți imediat undeva când își ia capul Rareș de acolo
Perfect. Țineți.
cum se văd câmpurile MRC-ul, cum se mișcă aici și radioterapia a început. Când pacienta nu mai poate ține respirația, să vedeți că
Ușurel expirați, doamnele.
ok, mașina se oprește și așa mai departe. Am studiat, am măsurat diferențele pe dozimetriile. Cât de bune le-am putut noi face, tot ce cu albastru este în free breathing, tot ce cu roșu este în deep inspiration și am demonstrat pe primii pacienți că reușim o scădere cu 60%. Cam asta trebuie să fie reperul. Deci mean dose în inimă reușim să o înjumătățim cel puțin. De sub 3 grei, mean dose, it's not bad at all. La fel pentru V20, V5 și chiar și pentru plămâni. Deci, avem precizie, avem o metodă care ne permite intrafraction, urmărirea modificărilor potențiale și să le și corectăm în timp util. Este confortabilă și pentru echipă și pentru pacienți. Avem o dozimetrie îmbunătățită pentru inimă și chiar dacă e cu prețul unei moderate creșteri în timp, safety comes first. Deci, suntem în Ardeal. La noi nu-i repede. Bine. Și după aceea, dacă se poate. Am publicat experiența, sau în fine, și principiile și experiența într-un manual care vi-l recomand, fie că sunteți radioterapeut, fie că sunteți oncologi medical, de către colegii noștri de la UMF din diverse departamente, cardiologi în principal. Și răspunsul scurt ar fi da, e o tehnică foarte bună și vedeți în ghidul german din 2019, Use of deep inspiration as the best heart sparing technique, în DEGRO, ghidul societății germane. Și to make a long story short, dacă ar fi să fiu extrem de concis, confidence, comfort, interfraction, movement, safety, efficiency și vă mulțumesc pentru atenție. Colegilor noștri tehnicieni, în primul rând, mulțumiri, colegilor medici din echipă și, desigur, fizicienilor.
Mulțumim. Întrebări, dacă aveți. Poate că sunt întrebări care sunt legate de acest subiect, adică iradierea sânului și poate că e o idee să le răspundem acum. Dacă nu, atunci mergem mai departe.
Colega și prietena mea, Renata Zacu, va vorbi despre limfome și plămâni, controlul mișcării.
Mulțumesc. Am să vorbesc un pic despre radioterapia cu diverse tehnici în tratamentul limfomelor și tumorilor toracice bronhopulmonare. În momentul când iradiem toracic, și nu vorbim despre sân acum, problema noastră majoră este toxicitatea acută, de multe ori esofagita, dar toxicitatea tardivă la nivel pulmonar și cardiac, pentru că complicațiile acestea pot afecta foarte mult calitatea vieții. Și un interes particular avem pentru pacienții cu limfoame, care sunt pacienți tineri cu o expectanță de viață prelungită și unde totuși există un risc de pneumonită radică de 8 până la 15%, în ciuda faptului că dozele de iradiere sunt în jur de 30-36 de grei. Și riscul de cancer secundar radioindus crește odată cu trecerea timpului. Din nou, aici devine o problemă serioasă. Iar la pacienții cu cancere bronhopulmonare, din nou avem un interes particular pentru scutirea plămânului, pentru că acești pacienți deja au probleme respiratorii, majoritatea sunt cu bronșite cronice sau emfizem, deci au o funcție pulmonară deja afectată și odată cu progresele în imunoterapie vom avea tot mai mulți pacienți bronhopulmonari de supraviețuitori de lungă durată și vom vedea mai multe complicații tardive ale radioterapiei. Dacă am vrea să facem o predicție pentru pneumonita radică la limfoame, grupul de studiu de la MD Anderson au venit cu o nomogramă care ia în considerare în special dozele la plămân, parametrii de V5 și parametrul de mean lung dose și împarte pacienții în 3 grupuri de risc, la cei la care atât V5-ul sub 55 și mean lung dose-ul sub 13,5 se poate obține. Sunt pacienții cu un risc foarte scăzut de pneumonită radică, la care se poate obține doar mean lung dose-ul, dar nu și V5-ul, care este de fapt volumul care primește 5 grei, deci volumul acela de plămân iradiat cu doze mici. Sunt încadrați într-un risc intermediar, riscul de pneumonită poate să fie de 24% și dacă niciuna dintre parametrii aceștia, constrângerile acestea nu se pot îndeplini, riscul crește foarte mult. Și nomograma respectivă e ușor de folosit, e cu un sistem de punctaj. Desigur, contează foarte mult dacă pacientul este tratat pentru o boală relapsată sau primar cu radioterapie. Toxicitatea cardiacă la limfoame, din nou, este o problemă pentru că cu radioterapia noi producem niște leziuni microvasculare, fibroză și toxicitățile sunt nu numai la nivelul arterelor carotide, unde odată cu mean heart dose-ul de peste 20 de grei avem de 2,5 ori mai mare risc pentru o boală coronariană, dar problema este, cum a zis și domnul profesor înaintea mea, cu boala valvulară, care crește vertiginos după peste 20 de mean heart dose, peste 20 de grei, și insuficiența cardiacă, care insuficiență cardiacă este de interes deosebit pentru că acești pacienți, majoritatea lor, primesc antracicline. Și dacă doza de pacienți care au avut antracicline, chiar dacă acel mean left ventricular dose este respectat, au 11,2% risc, iar dacă dozele sunt și mai mari, riscul se triplează. Deci poate că este o idee să începem să conturăm substructurile inimii și să încercăm să facem modificări în tehnică ca să obținem doze cât mai mici la inimă. Și de fapt asta a fost cumva evoluția radioterapiei în limfoame. Cel mai ușor a fost prima dată reducția câmpurilor și odată cu chimioterapiile mai eficiente, acum suntem undeva la involved site și desigur dacă avem PET-CT ca staging la debut, putem să fim și mai preciși în iradierea limfoamelor și să facem doar involved node. Iar aceeași lucru, reducerea de doză, a fost observată acum la early favorable. Deja recomandările sunt cu 20 de grei, bazat pe studiile de la German Hodgkin Group. În ceea ce privește evoluția tehnologiei, ce ne-a ajutat tehnologia în limfoame? În primul rând avem tehnici mult mai conformaționale decât APPA-ul acela sau câmpul de manta care se folosea. Avem imagistic, adică radioterapie ghidat imagistic, putem să reducem marginile de la CTV la PTV. Avem acest respiratory motion management care o să voi prezenta în detaliu și desigur putem să facem tratamentele deja PET-guided dacă avem bilanțul și reevaluarea cu PET-CT. Tehnicile, în principiu, deja 2D-ul nici nu mai este amintit în această publicație, radioterapia 3D, desigur, tomodirect, cine are tomoterapie știe că se poate face acest lucru, tehnici de IMRT, VMET și acest butterfly VMET despre care voi vorbi și care este o chestie foarte simplă și elegantă în unele situații. Ce ne ajută IMRT-ul? IMRT-ul ne ajută să reducem dozele mari, adică dozele care sunt în mediastin la inimă și în doza de plămân care este în apropierea mediastinului, însă ne crește doza periferică, acea baie de doză, motiv pentru care necesită poate unele tehnici adiționale această tehnică de intensitate modulată. Butterfly VMAT-ul, nu știu cât dintre dumneavoastră folosește această tehnică, noi am început de câțiva ani la cazuri selectate să facem planurile cu câmpuri non-coplanare, practic imităm fieldurile sau câmpurile acelea paralele opuse, pentru că majoritatea dozei intră anterior și posterior și reducem astfel să intră doză prin plămâni și prin sâni. Desigur că necesită o expertiză ca să faci un plan bun de IMRT Butterfly și destul de multă optimizare. Avantajele care sunt aduse de această tehnică este reducerea dozelor la plămâni și reducerea acelei băi de doze de V5 la nivel pulmonar și la nivelul sânilor. Dacă ne uităm la recomandările de la societățile internaționale pentru limfoame, min hard dozul ideal este sub 5 grey sau între 5 și 15 grey. Breast, în special la femei, min dozul sub 4 grey și lungul care am mai discutat, unele recomandări sunt chiar sub 10 grey ca și constrângere. Cum ajută managementul respirației să obținem doze mai bune? Sunt mai multe publicații. Una dintre publicații vine de la grupul din Danemarca, care doamna Specht de acolo este și președinte la ILROG, este grupul de studiu pentru limfoame și care are foarte multe ghiduri cum să iradiem limfoamele. Deep inspiration breath hold-ul, de fapt, ce ne ajută este să tragem inima în jos, cumva în afara câmpului, în cazul în care iradiem mediastin superior, plămânii sunt plini de aer și cresc volumele foarte mult, astfel reducem dozele mari și intermediare. Și aici se vede o comparație între tehnica 3D, în free breathing, tehnica 3D cu deep inspiration, IMRT free breathing și IMRT in deep inspiration. La doza medie în inimă, tehnicile în deep inspiration reduc doza medie la cord, la fel la doza medie în inimă. Doza la sâni nu este redusă, după cum vedeți la tehnicile de IMRT din cauza acelui dose bath. Și ce este interesant și am pus aici este doza la tiroidă. Și au și specificat în publicație că tiroida nu a fost conturată inițial. Deci aici au pus tiroida ulterior în planul și au văzut ce doză au primit cu diferitele tehnici și concluzia este că tiroida trebuie conturată la limfoamele mediastinale pentru că avem doză de iradiere și trebuie inclus în optimizare. Deci breast cancer, riscul estimat a fost cel mai mic cu tehnica 3D. În schimb, când s-a luat toate riscurile cumulative de myocardial infarction, cancer de plămâni, cancer de sân, cancer de tiroidă, riscul era cel mai mic cu tehnicile care foloseau deep inspiration breath hold. Într-o altă publicație cu 20 de pacienți, deci nu un număr foarte mare de pacienți, ce m-a frapat și pe mine, unde s-a comparat Butterfly VMAT-ul și în full, deci Butterfly VMAT-ul cu deep inspiration sau fără. La fel, tehnica de deep inspiration aduce beneficiu în min lung dose, în V5, după cum vedeți, inclusiv la Butterfly VMAT și la free breathing VMAT, aduce VMAT-ul și deep inspiration-ul și mai mult la full arc. La min hard dose, deep inspiration-ul la full arc, la Butterfly VMAT crește un pic doza la inimă pentru că doza vine prin mediastin, deci acolo ajută mai mult la reducerea plămânilor decât la min hard dose. Iar asta este breast 4 grey, din nou tehnicile de IMRT au doză full arcul, în special un pic doză mai mare decât tehnicile de Butterfly, unde cumva se evită ca să intre câmpul de iradiere prin sân. Deci avantajele sunt în special acestei tehnici de Butterfly VMAT combinat cu Deep Inspiration pentru doza la inimă și la plămân. Se poate suprapune breath hold-ul cu arcurile parțiale care se folosesc și, desigur, beneficiul este individualizat. Deci întotdeauna depinde fiecare caz ce extensie are în mediastin. De exemplu, la un caz cu extensie foarte mare paracardiacă, beneficiul deep inspiration-ului nu va fi așa de mare, în schimb, IMRT-ul, tehnica de IMRT aduce un beneficiu mult mai mare față de un 3D conformațional, pentru că va putea scuti inima mult mai bine. Iar pentru a reduce doza la sâni, acolo este preferat butterfly VMET, așa folosim și noi la pacientele de sex feminin. În experiența noastră avem 18 cazuri de limfome pe care le-am tratat cu Deep Inspiration Breath Hold, în VMAT sau Butterfly VMET și avem și un caz de gastric, deci un limfom gastric. Ce folosim este Align RT sistemul, e o complianță mare, tratamentul este relativ rapid pentru că sunt pacienți tineri și aici vă arăt cazul care tocmai este în tratament în acest moment, pacient de 18 ani, cu un limfom clasic, mediastin superior, cu adenopatii, după cum vedeți, și mediastinul posterior, nu numai în mediastinul anterior, cu o remisiune foarte bună pe examenul CT, pe PET-CT este negativ și la care am optat pentru tehnică cu Deep Inspiration Breath Hold. După cum vedeți în imagine, undeva 4 cm este cât coboară diafragmul în respirul sau inspirul reținut, iar volumul pulmonar, deci ăsta e left lung și right lung, se dublează aproape, deci la left lung este aproape dublu, cu tehnica de inspir reținut. Și așa dozele noastre au fost min lung dose de 6,7 grey, V5 36,7, V20 12, min heart dozul este 7,6, deci vedeți nu-i sub 5 grey, dar acolo este foarte mult, depinde până unde coboară limfomul și unde ai adenopatii, iar tehnica în acest caz a fost un VMAT obișnuit cu două arcuri parțiale anterioare, două arcuri parțiale posterioare, iar ceea ce am discutat, CBCT-ul nu este înlocuit. Deci SGRT-ul este doar o chestie adițională, un ajutor în plus, iar legat de partea aceasta de zonă de referință, deci dacă vedeți ce s-a desenat ca și region of interest, este inclusiv partea aceasta inferioară, să avem informație. Aici cred că am făcut și eu înregistrare, ar trebui să pornească dacă dau enter, nu?
Și țineți.
Deci pacientul trage, are feedback-ul de la tehnician, ține foarte bine. Acesta este CombimCT-ul și asta aș vrea să vă spun că la acest caz, deci complianța este atât de bună încât tânărul acesta aproape că ține un arc, un full arc. Acum, durata unui full arc este aproape 1 minut la un CBCT fast. Depinde sigur de protocolul folosit, el este capabil să țină undeva 45 de secunde. Acum, un caz de sân, de obicei nu-i capabil. Acolo și facem 20-30 de secunde, facem numai half arcuri, că oricum se iradiază doar un singur perete toracic sau un singur sân și putem obține și de la un half arc sau deci o jumătate de arc de CBCT informație anatomică ca să facem matching-ul. La limfome nu avem acest lux, acolo ne trebuie un arc întreg și pacienții aceștia fiind tineri, ei reușesc să țină. Aici cred că este deja parte de tratament. Trage aer, toți parametrii intră în limite, gating-ul de fereastră e cu 3 și ține foarte bine și acum fasciculul este pornit. În momentul când este dintr-un parametru, fasciculul este oprit. În limfomele gastrice, desigur sunt rare, dar cele low grade, deci de zonă marginală, sunt boala radioterapeutului, adică ar trebui să fie tratate dacă eșuează, partea asta de Helicobacter pylori, prima dată de radioterapeut, după aceea sunt tratamentele de hematologie. Și acest review retrospectiv descrie 10 pacienți Desigur, în momentul când stomacul, adică diafragmul, se îndepărtează de la inimă, scazi foarte mult doza la inimă. 10 pacienți au avut un median mean hard dose 2,5. Eu am tratat un singur caz cu limfom gastric malt. După cum vedeți, diafragmul este undeva cu 3,5 cm, cred că 3,76, cred că, coborât. Acesta este câmpul, este practic tot stomacul. Mean hard dose-ul la noi a fost 3,5 grei, mean lung dose-ul 4 grei. Ce cred că aici trebuia să facem altfel? Acum, sigur, aș face altfel, aș face mai multe achiziții în breath hold, pentru că inclusiv cu breath hold mai există mișcare reziduală și aș face poate cu un ITV și cu un volum intermediar pentru a mai vedea mișcare adițională. Bun, și de la limfoame putem trece la cancerul bronhopulmonar, unde sigur sunt două aplicații pentru surface guidance. Ar fi dacă folosim acest deep inspiration breath hold pentru radioterapia de non-SGRT, adică radioterapia convențională, și pentru setup assistance atunci când folosim radioterapie stereotactică. Probabil că toată lumea ar crede că un cancer bronhopulmonar sau un pacient cu cancer bronhopulmonar poate nu e capabil să țină breath hold. Și inițial și noi aveam reticență în acest sens, dar sunt studii care ne arată, și aici este în cadrul unui trial clinic, care știm că sunt foarte bine controlate trialurile și protocoalele, că este fezabil și pacienții au fost capabili să țină 20 de secunde. Desigur, se pune problema dacă aduce vreun beneficiu dozimetric acest breath hold și s-au făcut în trialul respectiv plan în breath hold și în free breathing și s-a ales planul în deep doar atunci când cel puțin un grey a fost scăzut mean dose-ul la inimă și la mean dose-ul la plămâni, fără să fie influențat coverage-ul la target. Și cumva tabelul, decisional tree-ul acesta ne arată cum, pornind de la 88 de pacienți, cum toți ies pacienți, că nu s-au mai făcut motive logistice, a murit înainte de simulare. Din 88, 80 au fost traininguiți pentru breath hold și aici trainingul e și mai important decât la un pacient cu limfom. La noi de obicei pacienții fac cam 10 minute de discuție cu tehnicienii înainte de a intra la simulator. Vedeți, din 80, 8 n-au putut ține breath hold-ul, 72 au fost capabili, după aia 2 s-a mai pierdut că n-au putut ține și la PET-CT, după aceea aici, asta aș vrea să arăt, 7 pacienți n-au avut niciun beneficiu din planul de DIP și până la urmă au rămas 53, din care 3 totuși au schimbat pe free breathing pentru că în timpul tratamentului tot felul de probleme au mai apărut. Una dintre acestea este că pacientul la simulator ține, la aparat nu ține. Îs prea stresați, își pierd complianța pe parcursul tratamentului și atunci rar se întâmplă acest lucru, dar atunci trebuie schimbați în free breathing. Experiența noastră este cu 3 cazuri, abia anul trecut am început așa tip-til să facem planuri în breath hold și la cancerul bronhopulmonar. Au fost situații în care am vrut să facem, dar nu am constatat un beneficiu dozimetric, iar rata de complianță la studiul acesta este undeva la 70%. Deci, în principiu, poate că ar trebui să fim mai curajoși și să începem să tratăm pacienții în breath hold, în special că acești pacienți vor beneficia și de durvalumab de menținere, deci chiar vor fi supraviețuitori de lungă durată dintre ei. În ceea ce privește radioterapia stereotactică, în cancerul bronhopulmonar sau metastazele pulmonare, varianta de a face în free breathing, la noi în tehnică majoritatea facem în free breathing cu simulare 4D, facem setup-ul sigur bazat încă pe tatuaje și pe surface guidance și cu CBCT, iar am avut și noi problema, frica aceasta că ce se întâmplă în timpul tratamentului, ce este acel intrafraction motion, cum este controlat. Înainte să avem surface guidance-ul, mai făceam inclusiv CBCT între arcuri sau între câmpuri, depinde dacă erau arcuri sau IMRT, step and shoot, ca să ne asigurăm că nu există mișcare intrafracțională și desigur făceam și un final CBCT la sfârșitul tratamentului. Deci la început corecție, CBCT, după aceea tratament, CBCT intermediar, tratament, CBCT la sfârșit, deci e un proces destul de îndelungat. Desigur, întrebarea s-ar pune că acest intrafraction motion, de fapt, cât de mult este clinically meaningful. Adică poate că dozimetric vedem câteva procente îmbunătățire, dar clinic, dacă este aici, este un open discussion, vom avea poate date pe viitor. SGRT în deep inspiration, desigur la cei la care pot să ține acest deep și aici aș spune o mențiune că noi avem și la simulator SIM-RT, adică este sistemul și avem cameră și la simulator și poți să vezi dacă pacientul într-adevăr poate să ține, să vizualizeze acest lucru pe ecran și să vezi leakage-ul, că sunt pacienți care țin deep-ul, după care scapă și vezi cum au ieșit. Și atunci asta se poate verifica încă în momentul simulării. Dacă se face în Deep Inspiration SBRT, desigur ideal ar fi să ai triple F-LINEC și să ai tratamentul foarte rapid și acest fast CBCT și tehnicienii știu și trebuie să vă jucați un pic cu protocoalele de Combim CT, să vedeți care este durata a protocoalelor, pentru că contează foarte mult să fie full arc pentru verificare. Bun, un workflow este în lung SBRT, în Deep Inspiration, este poziționarea pacientului, sigur se poate verifica surface guidance și CBCT la început în Deep Inspiration, deci aici este provocarea ca să poți să faci CBCT-ul în Deep, după aceea corecțiile, după aceea CBCT-ul de verificare, după care se mai verifică încă o dată. La noi etapa asta cu MV Portal lipsește în fluxul nostru. Nu prea am înțeles de ce aici au pus această etapă, poate că fizicienii o să-mi explice și dacă totul e în ok, atunci treatment delivery în Deep Inspiration. Bun, în concluzie, respirul profund reținut ne oferă posibilitatea să reducem marginile, să reducem toxicitatea cardiacă și pulmonară, în special dacă facem și combinații cu diferite tehnici de IMRT. Pacienții cu limfom sunt candidații ideali pentru Deep Inspiration și pe partea de cancer bronhopulmonar încă nu avem așa foarte multe date pe Deep Inspiration, dar cred că aici este chiar un window of opportunity să vedem pe viitor, să adunăm cazuri și sistemul de Align RT pentru noi a fost, să zic așa, un aer proaspăt pentru tratarea acestor pacienți. Mulțumesc!
Mulțumim, Renata. Întrebări, vă rog, before getting into deep learning and artificial intelligence, let's keep it shallow learning.
No questions. Da. Înseamnă că am prezentat foarte bine cu toții până acum.
Haideți să vă pun eu o întrebare care să vă... Mulțumesc. La care să vă gândiți între timp. Vă ajută acest sistem pentru verificarea non-coplanarelor, pentru câmpuri non-coplanare? Că știți bine, la non-coplanare ai o problemă cu CBCT. And this is an important aspect. So, is this system helping you to have better accuracy for non-coplanar fields? Veți auzi răspunsul în prezentarea următoare, da? Ok, da. Da, răspunsul este da și important, că veți trece la stereotactic radiotherapy și non-coplanaritatea asta chiar oferă soluții care altfel nu le aveți. Deci it's an add-on și acum când primim, sperăm noi în 2 luni, versiunea advanced, ne va ajuta că am avut câțiva pacienți cu sarcoame de membre, so limb sarcomas, în care știți foarte bine că e extrem de important exact cum stă flexia extensia și sistemele de contenție, fiecare au limitele lor și ne bazăm pe acest sistem ca să facem un pas în față și pentru sarcoame, pe lângă toate avantajele care le-ați văzut vis-a-vis de bărbie, brațe, care sunt relevante și în sân, dar și în orele, de exemplu, când ai altfel umărul pus acolo sub mască și tu te trezești cu o radiodermită care nici n-ai văzut-o în dozimetrie, vei putea avea explicații și să documentezi cauza și să o îndrepți din timp. Da, ne încredințăm într-un moment static al mașinii. În schimb, acest sistem îți permite să vezi ce se întâmplă all long treatment, intrafraction motion. E foarte important. Și când am întrebat, după ce am trecut de faza inițială de stres, ca și orice tratament sau orice device nou, toată lumea era ultra relaxată. Toată echipa medicală. Te simțeai în control, adică you really know what's happening. Și nu aveai neliniști metafizice acasă când te duci că, uai, ce-am iradiat astăzi. Ok, nu s-a vorbit astăzi, sau în fine, foarte puțin, despre alte faze respiratorii. Deci înțelegeți că acest tratament se poate face și în mid-inspiration și în end expiratory. Noi ne-am concentrat pe deep inspiration pentru că face diferența în favoarea unei doze mai mici la inimă, dar unii pacienți țin mai mult respirația într-o altă fază respiratorie. Evident că trebuie să aveți și 4DCT. Deci acesta, integrând timpul în inventarierea imaginilor, deci în achiziția de imagini, și la fiecare pacient veți putea decide după un coaching cât timp poate ține respirația sau nu. Dacă mergeți, sărim acum de sân și deci ne poziționăm în stereotactic. Dacă mergeți pe conceptul ITV, free breathing, în care lași mișcarea să curgă liber în condițiile în care durata tratamentului e foarte lungă, la 10 grei, 15 grei, 20 de grei, sau faci într-o anumită fază respiratorie, particular pentru pacientul respectiv, poate bunicuța respectivă ține cel mai bine în end expiration. Cum facem, de exemplu, stereotaxia pentru ficat, care, sigur, asta e referința. Deci o mulțime de lucruri se deschid în fața dumneavoastră. Dacă înțelegeți corect conceptul din spate și aplicabilitatea lui, veți dormi mai liniștiți. Că ați făcut ceea ce trebuie și ați verificat tot timpul corect. Au apărut întrebări între timp? Cu curaj? Te rog.
Cele 3 cazuri care le-ați avut de deep inspiration, ar fi fost interesant, nu știu, la workshop poate se detaliază, ar fi fost interesant, da, de plămâni, de văzut exact cât au putut să țină, cât a durat tratamentul prin asta, cât s-a prelungit.
Vă spun în persoană, pentru că teoretic sunt pacienți de trial, sunt trial și nu avem voie să arătăm imagini fiind pacienți de trial. Motivul pentru care am forțat deep inspiration la acești pacienți a fost pentru că criteriile în trialul respectiv erau atât de harsh la plămâni, încât în free breathing nu reușeam să obținem criteriile respective și desigur erau și volume pulmonare ciudate cu mediastin contralateral și ne-am ajutat cu deep inspiration-ul pentru acel V5. Acolo aveam probleme. Care nu știu câți dintre dumneavoastră verifică V5-ul în cancerul bronhopulmonar.
Verificăm de obicei.
Da.
Da, m-ar fi interesat, de exemplu, cât timp au putut să țină deep inspiration și cât a durat tratamentul din cauza asta. Deci, de exemplu, cum a fost 2 arci și când s-a întrerupt tratamentul și cât a durat datorită.
Pot să vă spun astea ulterior. La linfom pot să vă spun că face tânărul acesta în 7 minute. 7 minute cu CBCT cu tot. Deci el e recorder acum la noi în clinică. Colegii știu pentru că face un CBCT aproape full arc în undeva 45-55 de secunde. Se face matching-ul, care suntem încă la 2 minute, și după aceea are 4 arcuri parțiale și alea le ține 20-30 de secunde și numai cât se mută aparatul de la un arc adică de la start point la altul. Deci în 7 minute este gata. Însă, la o pacientă, să zicem, de sân sau un bronhopulmonar care nu ține unde trebuie să te oprești, să faci, este când și 22 de minute este pe masă. Da. Deci noi avem sloturi, dacă nu mă înșel acum, de 9 minute pentru tratamentele standard, fără motion management și unde facem deep inspiration, by default punem slotul la 15 minute. Chiar dacă poate ulterior pacientul o să reușească în 12 minute să facă, dar extindem slotul. Dar avem paciente care cu sân, perete toracic, mai în vârstă poate, unde și 22 de minute poate dura un tratament.
Aș putea să-i răspund și eu, doamne doctor, că avem și noi un set de pacienți la radioterapia convențională cu Deep Inspiration și am observat că dacă folosim o sesiune de training în care le explicăm pacienților și eventual folosim și VCD-ul, acea tabletă pentru training, în general, cu mici excepții, reușesc să țină. Acum, viteza de livrare și un CBCT la noi durează cam 50 de secunde, deci un fast CBCT, nu ultra fast. Și avem foarte mulți pacienți care reușesc să țină un CBCT. Iar dacă vorbim de radioterapia, mă scuzați, și cu mască. Dacă vorbim de radioterapia stereotactică, acolo utilizăm energie FFF, în care avem un dose rate foarte mare și tot cam 10 minute durează, dar 10 grei, nu 2 grei. În principiu, cam 10 minute la 10 grei. Noi folosim RGSC, care este Respiratory Gating System for Cameras. Este un marker block care se pune fie pe abdomenul, fie pe toracele pacientului în funcție de ce tip de respirație are. Și noi prima dată am avut emoții cu Deep Inspiration, dar ulterior, tratând tot mai multe cazuri în Deep Inspiration, este tehnica preferată chiar și free breathing-ului. Cumva. Pentru că ai și o siguranță mai mare, putem folosi margini mult mai mici și la radioterapia convențională și cu atât mai mult și la radioterapia stereotactică și folosim într-adevăr VMAT cu half arcuri sau chiar și cu arcuri complete. Mai rar folosim IMRT la pacienți care nu pot să-și țină mâinile deasupra capului sau mai știu eu, alte situații particulare, folosim tehnici de IMRT ca să nu iradiem țesut suplimentar. Și nu avem probleme. Cred că 10% din pacienți nu reușesc să țină o tehnică de breath hold. Sigur, pentru plămân folosim deep, pentru abdomen folosim end expiration, pentru că mișcarea reziduală este mult mai mică în end expiration. 5 mm. În principiu și la stereo și la convențională, dacă folosim o tehnică de breath hold, folosim 5 mm. Acum, dacă folosim breath hold, putem pune și 3 mm. Dar noi nu avem surface guided, noi avem acest sistem RGSC și din păcate avem acel VCD doar pentru simulator și nu și la aparat. Și atunci, practic, este foarte important ca pacientul să audă bine, să fie destul de compliant, pentru că tehnicianul spune trageți aer în piept și mențineți. Iar acolo când este mențineți, acolo de fapt se produce un declic, pentru că unii pacienți, cum zicea și Renata, încep să scape. Și de fapt acolo ar putea să apară deficiențe în tehnică. Aș vrea să întreb dacă nu să folosiți 4D CBCT.
Nu.
Mulțumesc.
Mai este o întrebare aici?
Aș vrea să întreb la sân, complianța pentru Deep Inspiration, cam care este? Cam ce procentaj de paciente din cele pe care ați vrea să le puneți pe Deep Inspiration chiar sunt în stare să facă lucrul ăsta?
75% zice, 3 din 4.
Eu nu tratez așa mult sân, dar cred că cam pe acolo.
Depinde unde îți setezi threshold, știi? Deci dacă nu ești foarte busy ca department și nu ești în hipofracționare 2,67 grei, deci dacă mergi cu 2 grei și te mulțumești să faci în 6 ferestre de câte
20 de secunde.
20 de secunde. E ok, dacă vrei să fii mai rapid. Dar cu un pic de răbdare, foarte multe înțeleg. Am fost surprinși.
Da? Cumva compensează timpul pe care îl economisești la
Da.
poziționare cu cel pe care este, mă rog, datorat prelungirii duratei tratamentului.
Dar asta, timpul de poziționare câștigi la toți pacienții. Da. Că îi pui mai repede. De acord, deci de-aia nici n-am insistat pe prelungirea timpului. Nu cred că e o problemă nu cred că e o limită serioasă. Câștigi recuperând timp la poziționarea celorlalți pacienți.
Și cel mai mult se câștigă în timp dacă ai 3 tehnicieni pe aparat. Și cred că e factorul decisiv. Deci atunci merg lucrurile chiar foarte, foarte bine, pentru că 2 sunt înăuntru în bunker, poziționează și al 3-lea descarcă câmpuri, face partea adițională ce trebuie.
O întrebare un pic mai tehnică, așa. Ați avut vreodată cazuri în care ați fost constrânși geometric? De exemplu, nu știu, mă gândesc la un plan cu 2 sau 3 izocentre sau așa. Un volum foarte lung.
Dacă ai mai multe izocentre, trebuie să verifici fiecare izocentru, fiecare plan separat. Nu ne place să avem toate izocentre. Vrem să avem un singur izocentru, dacă ai o metafază, și să nu trebuie service guidance înainte de a face CBCT.
Da, exact.
Dar CBCT-ul le face oricum.
Da, normal, exact.
Deci, nu știu dacă înțeleg întrebarea.
Păi, de exemplu, noi...
Te muți unde trebuie că ți izocentru.
Da, ok, da, de exemplu... Nu, de exemplu, un craniu spinal. Noi tratăm cu 3 izocentre.
Da.
Și atunci...
Te ajută să-l poziționezi, surface guidance,
Așa.
și ai nevoie de CBCT-uri, 3 bucăți.
Deci 3 izocentre,
Da,
3
și foarte
CBCT-uri,
mare.
3 surface guided.
Foarte mare atenție la craniul caudal, ca
Da,
să nu ai overlapping-ul respectiv.
Exact,
da.
exact.
Deci,
Dar mă gândesc că atunci ar exista suprapunere între surface guided, cele 3 achiziții de imagini.
da, ar trebui să le ai la fel. S-ar putea totuși să intervină o modificare că e durata mai lungă, fiindcă ai 3 ori 2 grei.
Exact.
Și atunci te ajută sistemul, mai ales varianta asta advanced, inclusiv cu arcuirea spatelui, cu umerii, cu toate pozițiile periferice, dincolo, chiar dacă ești îndepărtat față de primul izocentru, ca să repoziționezi la fel de fiecare dată. Adică chiar dacă de la câmpul cervical, craniul cervical, la cel toracal sau dorsolombar s-a modificat, tu îl repui la fel, dar atunci apare problema aceasta că vei avea overlapping-uri. N-am folosit încă în craniul spinal chestia asta, tocmai fiindcă am vrut să evităm și mai binele la bine face rău, să retușezi încercând să poziționezi și să uiți că de fapt CBCT-ul și perfect matching la joncțiuni e ce e important. Deci, dar știu, colegii din Turcia au folosit.
I will translate the question because maybe it's interesting for you. So the question was that with craniospinal radiation, if there is use with surface guidance, or do you have experience with SGRT in craniospinal irradiation? We personally, we haven't done with SGRT craniospinal, but maybe you've got...
Yes, so some of our reference centers train them, especially there's a center in Germany, Bavaria, Bayreuth, which is a public center. They treat their craniospinals utilizing LINRT. So they use open face masks and the mask opening for the cranium positioning. They utilize postural video for general, let's say, body positioning. And they have, in the same way, 3 isocenters, 3 different isocenters to position the patients. So normally, when you select a field on your machine, since it's a connected system, it will select appropriate isocenter within the drop-down list. So you export your whole fields, your different isocenters into LINRT, so you have a possibility to switch between the isos as you are going further down the treatment. So first of all, you select, let's say, cranial fields, you treat the cranial fields, then you select on your treatment machine your thoracal, let's say a spine field or your cervical spine field, and then you would switch the ISOs accordingly, because the machine has the possibility to select the ISO center according to which field is prepared on the machine. And then you would go ahead and treat normally as you would. So you would perform your initial setup, postural video based setup. You would do auto couch motion to set the patient to the ISO first. You would do your imaging. You would, let's say, do your reference capture. And after this, you would go to a different field. And once again, yes, you can proceed with the treatment. So the way they do here in that particular center, they have a specialized, they produce the narrow MV planar images or narrow planar MV fields that look at the vertebrae. So they have the MLCs pulled in from the different sides that mark the vertebra start and finish on those MV, let's say, planar fields. They do the planar MV imaging let's say with MV imaging, and then check if the MLCs or the spokes of the MLCs marked, let's say, the start and the finish of the vertebrae correctly on the imaging post SGRT alignment. So they just do a CBCT once, and then they verify, they do the shifts with the SGRT. They can do shifts automatically with the couch, with a move couch option, and they verify this with this planar MV imaging to make sure the vertebrae are, let's say, aligned well within the fields. So I hope that answers your questions. So, yeah.
And by that, you are diminishing the dose that the patients receive, because we are speaking about pediatric patients. So the MV, it's and KV images, it's 10 times less, I guess. 0.5 centigrades versus 5 centigrades. Okay, I would like to go on if you agree, but we would be happy to answer questions afterwards. So we move to the last presentation, artificial intelligence-driven real-time adaptive helical and robotic radiotherapy technology and treatments. Nadine Kuchut? Sorry, no? No? It's Bora, yeah. Thank you. From Anadolu, no? Okay, never mind. I'll let you present yourself then. Thank you.
Hi, everybody. My name is Özgür Bora İmran. Slightly different approach we will continue. It's not about SGRT. We've been talking about wonderful product of SGRT, and we will have a demo just after this presentation, and it will take 15 minutes or something like that. We like to just talk about the artificial intelligence and new adaptive approach and the beam tracking options comes with the accurate solutions in 10 minutes. So, first, oh, it's not starting. Olivier? Okay, let's start again. Okay, it's working now. So let's have a quick, the evolution of the accurate systems. As you can see, all started 87 with the first CyberKnife production. And in 2002, it was a tomotherapy, and it's evolved. And these days, I would like to present to you the new ClearRT imaging system, which is new KV-CT imaging. And also, I would like to introduce the beam tracking options of tomotherapy, which is here. It tracks the tumor, moving the machine. So it's a real tracking and another option of just fixing the motion problems. So let's start with what is helical treatment first. And as you know, the helical treatment is similar to 3D printer actually. What we do is slice by slice, treating the tumor. It's not volumetric approach. It's totally different. So it's called helical tomotherapy treatment in gender. And because of that, we have very long treatment area, as you can see, up to 135. So we can treat very long tumors. So normally the MLCs, we have a very fast MLC. As you can see, this is real time. It's 50 times faster than any MLC, and it's constantly rotating, and the coach is moving. So that's why you end up with having a helical treatment. But also there is another option, which is called TomoDirect. If you like the tangential, any treatments like breast treatment or something like that, you can still use this feature, and it's not rotating anymore. It's going to certain angles and start to treat, and the coach is moving also. So there is a small comparison here. This is one of the MLCs, recent MLCs of the Linux, and this is a Radizac MLC. So it's 50 times faster, and you can see that you can distinguish how fast it is actually. It's rotating here, now it's changing, it's moving here. As you can see, it's binary and it's closing and opening, but this still needs to come all the way through. So as the treatments become dynamic, we need even more speed of the MLC. So this limits the IMRT level of the treatments. Sorry. And this is a slow motion, by the way. This is not real time, because if you open the real time, you can't even see the opening times here. And the result of this, we have a better dose shaping, and this is a real dose distribution. As you can see, this is the Marie Curie, Madame Curie's dose distribution on the film, and this is achieved by the Radizac. As you can see, the resolution, and this is 120 high MLC. And if you look at the comparison, it's having this kind of resolution. So let's talk about the new, they just launched in the Astro, this new feature of the Radizac, which is a new helical fan beam KV-CT. So basically it's a normal CT, simulation CT inside the Radizac anymore. It's not a mega voltage fan beam CT, but now KV-CT. And what they put in, the previous option was only the MV and CT detector here. They implement KV source and KV detector here. So you have two options now, MV fan beam CT and helical fan beam KV CT. So having this is increased imaging quality and faster imaging. For example, here, as you can see, is helical, real simulation. I mean, it's a real simulation CT. It's not anymore comb beam CT anymore. And it takes only 15 minutes to 20 cm to take image, and 1 meter is in 1 minute. And the better things is the dose is 0.9 centigrade if you compare to comb beam CT, almost 10 times less dose to the maximum dose anywhere. And the FOV is 50 cm is pretty good enough to cover whole body. And there is you can see you can comparison the CT simulator and Radizac IGRT. It's almost the same quality, and it's hard to distinguish actually. Maybe you can understand this is the simulation CT because it has a contrast, as you can see, and this is a simulation, and this is the IGRT, and this can be used for dose calculation. So this comes as the automatic adaptive options, because you have everyday single image, a single CT which can be used for dose calculation. So now let's move to motion synchrony, which is artificial intelligence guided real-time tumor tracking. So I present a very nice video to compare whether the motion management solutions are. And if you think of this water as a dose, and you don't want to splash any dose around, because the more water you splash around, it means you're giving the dose surrounding areas. So I trying to do this with the CyberKnife and Radizac. This is an ITV treatment. If you have any technology, you have to choose the ITV, and it's a large volume, but the tumor itself is this small. Now we're using some embolizations to fix the patient. It's invasive and also it's comfortless, but you have a still splash around it, so you know giving the dose to surrounding tissue. So this is the gating solutions. You have a still ITV, narrow ITV, but you're splashing the water around because during some window, still receiving the dose. So better solution is that, but this is really hard to do because you have to move the beam itself, so LINAC itself. So this is a good explanation of what is precision and what is accuracy. I was always confused about those things. So this is, as you can see, this is low in precision and low in accuracy. And this is high in precision, but low in accuracy. So to be, to do the best, it has to be high precision and high accuracy. If you have a LINAC solution and you come to, SGRT solution like this, SGRT provides you this to do this, basically. So it becomes more accurate and your treatment will be precise and accurate. Because of this, as we discussed a couple of slides ago, this is the normal ITV. It's a very large tumor beam. So if you do the gating, you cut some ITV margin gets basically shortens, but still you have an ITV and volumes increases. But if you have an ITV-free treatment, which if you can do the tracking, real tracking, and you don't need any more ITV. So the volume differences, as you can see, it can be up to 3 times. This is the Secroni plan with the Radizac, and this is the ITV plan, and the volume almost 3 times. And of course, it gives us the advantage of the spare the organs more. And this is how it does it. First, you have to detect where the tumor is, and then it will move the machine. But first, it needs to detect. So as you can see, it has an optical camera here. It detects the briefing cycle, and every 2 seconds, it takes the KV image plus artificial intelligence algorithm, which CyberKnife using almost 10 years. And you end up with seeing that where the tumor is right now and where will be in the near future, and it keeps updating every image taken, every brief is taken. So it's now the hard time to move the machine, basically. If you move it on the longitudinal direction, which is superior-inferior direction, the jaws itself moves. As you can see, the fish moves on the superior direction, jaws follows. If the movement on lateral or Z, the MLC pattern is shifting. So MLC are doing exactly the same, but what they do is just shifting the pattern to the left and right. It can be done by Radizac because its opening time is 10 milliseconds. So when you decide to shift the MLC to the right or left, it just takes 10 minutes to go this side or this side. The normal MLCs cannot be done because MLC is too slow to shift the one pattern to the right or left. And this is a real treatment image, as you can see, with the tracking of the Synchrony, tracking Radizac. And you never see, its beams always direct to the fish, which is target. And here with no motion compensation, as you can see, it's just missing all the time. So because of that, you have to draw the ITV to, not to miss the target, basically. And this is a real beam, as you can see, because this is a scintillation water. It's not a real water. And in the dark, you can see the beam itself. So this is the real beam going through. This is one of the first patients who has been treated by Synchrony with the Radizac, and it's 18 gray per fraction, and it takes only 9 minutes beam on, and door-to-door is 19 minutes. And let's talk about artificial guided auto-adaptive, which is going to be very, very good news in future. Right now, the system is every day is taking IGRT, right? And IGRT is a KVCT. It's not a cone-beam CT, and it can be used for dose calculation. So system automatically on the background take that KVCT and start to calculate the dose every day. And it's let's suppose it's a 15-day and you want to check the dose distribution. So it gives you the one-click report. On the left, this is initial plan, And as you can see, your initial plan is here. Left parotid was 24, which is green flag, less than 26 because it's less than the dose constraints. On the right-hand side, the moment it's receiving, so real dose. Let's not say the real dose, but the more realistic dose. So it was the simulation, and now this is the everyday CT scan, everyday anatomy, and everyday position has been calculated, has been into account. And as you can see now, it looks like that left parotid is receiving 27, and it's red flag because you will start to see the side effects in the future. So it gives you the advantage of the decision whether to do adapt or not. So we haven't done the adaptive yet. Just gives the information, because in early days you have only just assumption that the patient gets thinner, weight loss or something, and dose distribution has been changed. But you have no idea how been affected by the dose, PTV coverage or the organ sparing has been, how it affected by that. But you have a real numbers right now to make the decision. And if the end of the treatment, if you look at this report, you can, not the middle of the treatment, like 15 days, you can check this report after 1 month, basically, after the finishing treatment. And this is gonna give you the treatment report. This is what you plan, and this is what you get. And you can understand that either you give the right treatment or not, are you expecting some side effects or not, or something like that. And this is a very new, so this is a on coach. This is, let me play. So this is a movie of on coach online adaptive with the Radizak. Like MR, as you know, MR is doing online adaptive. It means that every day you are doing new plan, not a one plan or two plans during the 30 days. You're doing every day single one plan. So every day needs to be contoured and every day is replanned. So this is it can be done by Radizak. This is the first example of it. As you can see, SGRT has been taken and the sheet has been taken and it's asking, would you like to adapt new plan? If you click yes, it will take you to planning. Here is the plan. And within a couple of minutes, you have to review the contours has been moved to the new image. Doctors just needs to review the contours if it's correct or not. Doctor is now reviewing the contours, if it's okay, or if it needs editing or something like that. And just after that, it will take only 2 minutes to create a new plan. So doctor is checking all the contours on the new image set. Now we are moving to the next step, which is the plan. Now it's moving to create the plan similar to automatically AI trying to create the new plan exactly similar to the previous original plan. And you can see the differences. This is the previous one, and it will show you on the dot the new one. And you can see, and you can decide to apply the new plan or not. You can continue with the previous, or you can switch to the new plan. So it means that every day you can do new plan and it will take on a couple of minutes to finish the plan. And now, as you can see the ORs and the targets, how they've been affected by this new plan. And it gives the comparison. And this is real flow. And it gives you the report of the organs, if they are matching with the original plan. If it's not matching, it gives it flags here, and you just click that and then remove the dose. So you have options that play with the plan as well. So you don't accept the plan created. You can play with it. And now it looks great, and you just go to the treat. So it takes only this time, as you can see. This process takes almost door-to-door 45 minutes with mRNAx, but it will take only less than half an hour for sure, but it could be even 20 minutes to the everyday new plan and something like that. So if in summary, adaptive solution array is with the Radizak, Clear-RT, which is a new image, and because of it can be used for dose calculation. AI-guided online adaptive is possible now, tumor tracking, And next day, KVCT auto-adaptive. If you like to do the next day, which is offline adaptive, is regarded as offline, but actually it can be, seen as online as well. And it can be done on coach adaptive, like MR Linac, as we discussed, and within 20 and 30 minutes. If you compare with the Linac, MR Linacs, it takes almost 45 minutes to 1 hour. And in the future, we will have a spectral CT as well. It will allow us the tumor tracking without fiducial free. Now we can tumor track with the fiducial and fiducial free. For the lung, for example, we use fiducial free because it's very distinguishable, the tumor itself in the lung. But for prostate or liver cases, you have to use, of course, fiducials. But in the future, we're having the spectral CT. We will be distinguished wherever the tumor it is. Basically, what is the spectral CT? We have 2 CT scans, one with the high voltage, one of them is low voltage. So if you minus 2 images, you end up like PET CT image. It gives you the activity of where the tumor is. So that in the future, it's going to come like fiducial-free tracking options, but not available. On coach real time is available right now, but it's not available commercially. Still testing in the couple of sites. Maybe next Astro they will announce, and this is the. I'm telling you, you know now the rest before the rest of the world. Basically, this is really keep secret something, and next Astro they will announce the on-coach adaptive. And we have a new planning system which is called Volo Ultra. It is very, very fast because the previous the IDMS was almost takes 10 minutes to create this plan. This is not the beam on time. This is the how long it takes to create this plan. And now planning time is 90% reduction, which means that this plan can be generated within a minute. And it will give you the 60% beam on time reduction. So it will make the plan efficient as well. So for example, for 20 gray fraction, if you're treating Radixac door to door, it's going to be 7 minutes. Because of the fast KVCT, it will take just 15 seconds. And with the Volo Ultra, almost 90%, 60% reduction on the planning. So almost 2 minutes, 3 minutes. So you can achieve 8 minutes in total. If it's SGRT, door to door will be approximately 15 minutes. Let's talk about the quickly robotic surgery, which is the new CyberKnife S7. There's a small movie. Everything evolving, as you can see, from horse to the cars, and then become a Tesla. If you like the 60s design, it's still continuing in the other Linac designs, as you can see. Of course, they added software, power, everything, but the design is always the same. Let's move this too much. And treatment times has been changed with the S7, for example. This reputation for CyberKnife usually to have the really, really long treatment times. But nowadays, with the helping the MLC, it takes only 30 minutes to total beam on time. So if you compare the first gate 3 option, is 95% faster. And now we have MLC, as you can see, is the thickness is 3.8 millimeter. And is 100 oval travel option, and you can decide to use either MLC, iris, or fixed collimator. All of them will be available anyway. And how that makes the CyberKnife system, the tumor tracking, similar to Radixac, but they have only KV tubes on the ceiling, and it's diagonal, and it's taking the KV image online imaging. Don't forget that we don't have any COM-beam CT taking online. We use COM-beam CT for pre-treatment, but during the treatment, we need like something like SGRT, Vision RT product, so that we can have some idea of what's going on during the treatment, or like real KV imaging during the treatment. So there is another one movie. This is the similar of the Radixac. It's gonna treat the fish. So we reached 20 minutes and the presentation will end soon. Now the fish start to move. So everything is static, is nothing changing basically. But when it started moves, it will detect and move the beam accordingly. Now it's using the synchrony, which is the special name for tumor tracking. Now they will move the fish in the tank. As you can see, robotic arm follows the exact same pattern with the target. So basically, yeah. So what is SRS? What is the purpose of the SRS basically? The purpose of the SRS to creating peak dose. We want this kind of peak so that we have really high gradient here. Otherwise, we don't have the gradients. Why we want a gradient here? Because we want to be because we're giving high dose and we want to be isodose as sharp as possible. Because if it like IMRT, if the low dose spreads or the isodose spreads, it means that you give really high dose to all the organs around it. So normally IMRT approach is homogeneous dose. But in the SRS world, we prescribe the dose here. There is a price to pay, of course. There is an inhomogeneity here. There is going to be heterogeneity. But because to achieve the peak, this is the price we pay, basically. But this is in the tumor anyway. And to achieve this kind of peak, you have to give the dose from all the possible angle of the sphere, not only two-dimensional axial field, but you have to, you can think of as a dose of balloon. If you're doing the two-dimensional treatment on the axial and you want to decrease the dose somewhere, it will blow to some other parts, right? It will increase the other volumes. So to spread the dose, to make the isodose close as possible to PTV, you have to give to other areas some dose. Use the non-coplanar areas so that you get small dose to other areas, but in addition, in the you just create isodose shrink towards to the tumor. So to achieve that, you have to use this, all the possible angles on the non-coplanar. If you look at the hyperarc, of course, it will be better than the normal arc, but still using, this is the normal axial treatment, and you added two more additional arc, which is non-coplanar fields, but still you are missing some fields in the sphere. So, because of this, for gamma knife and cyber knife, which is using the sphere area, and you end up by very high dose gradient, you can achieve within 2 to 5 millimeters from 100% dose to 50% dose. And so you have a small balloon of dose. You can consider that. If you look at the Linac basis, minimum it can reach 4 millimeters. So you have a larger balloon because you have a hyperarc, you have a non-coplanar fits, but still needs more because it's not using the full advantage of the sphere. And this is the result of the accuracy of the cyber knife. As you can see, all of them less than 0.6, except this one. So it shows how accurate the system and precise the system. Thank you very much for your time. If there is any question, I'm happy to answer, and we will start the demo afterwards.
Thank you very much. So it was a hard afternoon. The exciting part is coming because you can see the demo and actually how this whole surface guidance is working. So it's just a short break to arrange the technical part, and then please approach the corner in the front. Okay, and thank you for your participation. Can we start maybe? So if you just proceed to the corner and we have a nice volunteer there. Yeah. And let's just see how it works.
Yeah, you can come closer. No, honestly. Please, please. What? No, no radiation here. As I said, tons of benefits, fully optical. So you can even not see it on the screen, on the skin of the patient. So nice. So once again, thanks for coming and participating into the SGRT community meeting in Romania. The very first one. So glad to have everybody here. I'm gonna give you a bit of a taste and demo of AlignRT advanced system utilizing our brand new Horizon cameras, which you can see here mounted on the tassels. It's pretty much similar to what you would have in your normal treatment bunker. So these are our, let's say, pride and joy, and we'll be using it to track our model today. Flavio, give a bit of applause for his efforts. Thank you. So as I mentioned in the prior presentation, here we have our Horizon cameras. And with Horizon cameras, we change a bit of a design. If you're familiar with our prior HD cameras, there's a bit of hardware changes associated to it. But the best and foremost is the resolution of the cameras is better as itself. So the hardware capabilities that the cameras can produce and the clarity of the picture and how much information they can capture in real time has increased as well. On top of this, we changed design a little bit. So now we have a double projector in the center of the cameras instead of a singular lens, which really produces the whole projection from head to toe of the patient. So you can monitor the whole body during the, let's say, setup and also with postural video. On top of this, these cameras can interface, as I mentioned, with the beam-side cameras for Cherenkov live dose imaging. So if you have a patient there, you will also have two lateral additional beam-side cameras that can track and register the Cherenkov light that's produced when radiation enters or exits the body. So you will have, let's say, a real-time dose fluence map projected on top of the surface, and you can see other things that you weren't able to see before. It's really making invisible visible with the new SGRT technologies. So I'm going to go ahead and start here. I have my treatment screen here. I have a larger version projected on top. Here's something I have as well. So this is my workstation that I utilize to control the system. As for a clinical installation, we have the workstation outside of the bunker where the Linac workstations are, as well as the inside the bunker too. And those workstations are mirrored. So whatever you're doing outside, so you have a therapist working on the patient's data outside, whoever's inside the bunker can see it, and the either way around. So you can actually control each other, see what other person is doing inside the bunker, and you have a full control of the system from each point of the access. So here I'm within the treatment screen. So within the treatment screen, I have a few things here. I have my plan, let's say, ready to go to treat. I'm treating these patients with the DIBH technique, and I have my reference surfaces loaded. So since, of course, I don't want to scan my model to give him additional X-ray dose, I have captured a new reference with the camera. So I have captured the new reference of my existing patient with the cameras. I'm going to be setting up according to that particular reference. So first and foremost, I have my free breathing surface. So this is where the patient is fully relaxed. They're not straining in the free breathing, and I can utilize postural video feature, subscription feature, and the deltas to accurately set up the patient. Let's see how well we did this. I know we moved a little bit. I captured and made him relax. Let's see if we can reproduce it well enough with this table. So here you see, again, a live video feed coming from the cameras. And what's overlaid on top, this is your reference surface turned into the guidelines. So this being guidelines is automatically processed by the software and overlays on top of your live feed. You can cycle between different cameras to look at different misalignments here. So here I'm seeing that, okay, maybe his left arm is a little bit in a different position. I can go in and slightly adjust it. And you can see it's, again, adjusted a little bit. So it helps that particular aspect of getting the armpit or the arm area off the radiation field, especially if you're treating the patients with tangential radiation fields. Here, I can cycle between the cameras to see how, let's say, my position is reproduced. I see it's pretty much similar. There are some discrepancies as well. So I have some millimetric changes, shifts I would normally apply. So if we have the system interface with the Linac, and of course, if the necessary software licenses are active, you can take this data, so this real-time deltas that are used for the fusion, and you have the matching in 6 degrees of freedom, and you can actually drive your robotic couch with these deltas to the isocenter. So you don't even need to manually adjust the patient's position. You don't need to free float the couch. You don't need to tug on the patient. With just one click of the button, by the way, the button is usually right here, where right now I have the empty space because it's not a connected system, but the button says send to couch, and you can send different degrees of real-time delta to the couch. You can just send the vertical, or you can set all translations or rotations, or for some particular, let's say, robotic couches, you can send all 6. So you can send even the pitch and roll. Okay? So if I am happy with alignment, and I believe alignment is good, I can, as I said, cycle between the different cameras, see what's happening with the arms. If also patient has the view of this, so if you are able to split and project it to the larger screen, some of our end users are even showing this to the patient, telling them, okay, go ahead and self-adjust into these guidelines. So you can have a possibility to make the patient fit into that geometry. So you're reproducing the same geometry as you had on the simulation. So if I'm happy with the adjustment here, I can go ahead and now switch to my breath hold surface. So as soon as I switch to my breath hold surface, I immediately see that, my deltas are out of tolerance, especially vertical is out of tolerance. I have other ones, longitudinal is out of tolerance, and the patient needs to inhale and reach that displacement to make sure that the breath hold is maintained. I can go ahead and, let's say, coach the patient to this. So you see the patient is holding the breath, and the treatment can continue as soon as the deltas reach about a value. So go ahead and relax, please. So 2 things I'm going to do here to make it a little bit harder for him to make sure the coaching is done here. I mentioned we have 6 degrees of freedom, right? Each 6 degrees of freedom have associated tolerance with it, and you can manually change it for each particular degree of freedom. There's different ways we can do it. We have treatment protocols associated with the thresholds. You can set different thresholds for different treatment protocols. Normally for SRS, it's set by default to 1 millimeter and 1 degree. For SBRT, it's set to 2 millimeters and 2 degrees. And for all other treatments, it's set to 3 millimeters and 3 degrees. But you can change it as, according to what site you're treating. You can even change it for a specific patient, like I'm going to do, and modify his thresholds a little bit. And I can also change it for a particular fraction. So if you want to, let's say, treat on this fraction the patient a little bit differently or change his thresholds, you are welcome to do so. So I'm going to go ahead a little bit, make it a little bit harder for him, and reduce my tolerances a little bit on the delta. You see, I reduced my tolerances here down to 2 millimeters. So, and I can have two options. I can either save it just for this session or for this fraction, or I can make the changes stick for the next treatment as well. So the breath holds are usually assisted with our real-time coach. So real-time coaching device is this, let's say, contactless coaching device where the patient sees where they need to inhale and where they need to stop. Usually you have this yellow bar, which you can see on the coaching device just below the postural video. And when the patient inhales and the vertical reaches normal threshold, the bar will go into the white space. The patient knows they've inhaled enough, and this is where the treatment will commence and be done normally. Of course, since also we have a direct connection to the LINAC, we can utilize automatic beam hold option to control the beam. So I just turn my beam control option on, I toggle this control. So as soon as the deltas will go into the tolerance in all 6 degrees of freedom, the beam will start to be on. So you can flip your real-time coach in any direction. The screen becomes automatically horizontal. So it's out there. It's attached to this metal flexible gooseneck, which you can attach to the table, or you can attach it to the breastboard or any kind of mobilization device. And you can give it any shape and any direction, and you can position in front of patient in any distance. You can utilize it with reading glasses, completely contactless as well. So just relax. You can inhale, and when the bar reaches the white space, you can go ahead and hold. Relax. Since it moved a little bit, we see not all the deltas are in tolerance. I'm going to go ahead and capture a little bit of a new reference. Go ahead and take a breath hold until this reaches the white space. You can relax a little bit. Take a breath hold until you feel a little bit of pressure. Don't need to strain yourself too much. When you're ready, inhale through the nose. Okay, hold it. Okay, you can relax. All right, so I'm gonna go ahead and make sure this is reproducible. So again, I'm gonna make him go into the breath hold. Okay, so now all deltas are in green, and the treatment can continue as it is. I'm gonna toggle the beam control option as well. He's relaxed out, so now the beam will automatically be held. Okay. So this is normally how the DIBH workflow works. You can utilize, again, connection with 6 degrees of freedom, and you can hold the beam in 6 degrees of deltas, and you're welcome to view everything in postural video. Make sure the patient is not back arching. If the patient is also back arching, you're going to see two things here. First of all, your pitch will be clearly out of tolerance, and also you will see discrepancy here around the abdomen area. So you'll see the non-zero residual pitch as the patient is going into the, let's say, a simulated, not correct breath hold. One other thing, which is nice here, I mentioned a little bit in the morning about the deformation feature of Align RT Advance. The deformation feature here actually tells me where I have some anatomical changes associated with my treatment. So here, the green overlay tells me that everything is within the tolerance, and the tolerance here is for me the 3 millimeters. So I've set it at 3 millimeters. I can come down as low as 1 millimeter, so I can even detect the changes as small as 1 millimeter or up to 3 millimeters. So this is a useful tool for your dosimetric analysis. If you believe your patient's geometry is changing during the treatment, if it's something's being affected, maybe you have a breast swelling there, or maybe you have a serum buildup, or maybe you have a weight loss, associated weight loss, you have a possibility and a good tool to observe where those changes happen, utilizing those surface statistics, and you can quantify those changes as well. You can see those changes not only around your region of interest or the area you're treating, you can quantify this over the full field of view of the cameras. You can see where those changes are. For example, here, it immediately tells me that his, let's say, left hand a little bit higher and the the right hand is a little bit lower. And there's some associated changes compared to what geometry we have. And I can quantify those changes and see where what part of, let's say, surface and my target is within those tolerances of set. So I'm going to go ahead into the beam hold again, see if we can reproduce it after a little bit of, let's say, rest. So Flavia, please, if you go ahead, inhale through the nose. You see everything is in green and the treatment can continue. And if I toggle my beam control, of course, when I'm out of tolerance, it's held. Go ahead and try again, please. Yeah. When everything is good, the beam will be automatically turned on. Okay? You can relax. Any questions associated with DIBH type of treatments? So as far as the DIBH type of treatments, we have, and we're utilizing the same concepts and the same possibilities to treat those patients with closed geometry. So when we have a closed ring entry like Halcyon and Ethos Linux, in this case, we have 3 cameras for the setup. So we utilize outside setup possibility to set up the patient outside utilizing the postural video. So we utilize all the same benefits, those pink guidelines, the camera features, all the views from the ceiling camera from all 3 different angles. But as soon as the patient is loaded into the treatment, so the patient moves into the bore, we turn into the inboard cameras. You see this plastic model here, where we have 2 miniature cameras fitted into the carbon fiber ring, and they actually track the patient in the same manner in 6 degrees of freedom in real time to produce the same effect when you have the closed bore gantry situation. And it actually controls the beam, sorry, it doesn't control the beam, there's no MMI interface with those machines, but it controls the breathing amplitude and reproducibility of the position in real time. So we can check and maintain if the position is the same, if, let's say, the breast and the chest roll is within the tolerance with 6 degrees of freedom and so on. Yeah. Yeah, please go ahead and block one of the cameras to see if it's maintained. So I'm going to go ahead and block the view from one of the cameras to see if the delta's changed a little bit. I'm standing next to him quite, let's say, quite close. Now, at the installation phase, we do something called advanced camera optimization, where we do a specialized calibration with a specialized calibration plate, where we calibrate the whole field of view of the cameras and every point with respect to each other. So this specialized calibration procedure called advanced camera optimization makes sure your deltas are more stable when you have occlusion effects. And it's unique to a line RT as an SGRT system. So that means if I'm blocking, let's say, the view of one of the cameras, my deltas are maintaining its stability. So I'm going to go ahead and try to block the view from one of the cameras. So I'm again blocking everything completely. You see there's some, of course, there's some changes. He's also breathing, of course, but as the tracking accuracy of the patient is still maintained within the same feature. Okay. One other things to consider here, you see right here on the lower corner, I'm going to show it here on this screen. It shows you the frequency of your fusion, or how often we're updating the position of the patient. So the speed, which AlignRT registers patient, or does the registration of the live surface to the reference surface, is up to 27 times per second. So we are really maintaining and watching the patient in real time and really detecting a very fast and quick and accurate motions. All right, thank you, Flavio. You can take down your hands. We'll do the SRS flow next. I'm going to remove my armrest, and I'm going to go into the cranial treatments. So when you finish the treatment, all of this deltas and real-time registrations that you see on your screen, all those numbers are saved as a treatment session. So all of those information can be retrieved. The system can and generates the reports every time you perform a treatment session. So all of those graphs are there for you in real-time graphs. You see where the treatment was done, where the beam was held, and where also the beam was delivered. You have the recordings of all 6 degrees of freedom for all the different deltas. You have saved this information. You can put it out into the report. You can put, if you see anything interesting on a screen, you can always grab a screenshot and put it into the report. And one other thing the system can do, the system can actually do your virtual SSD measurements, because we see the full surface. We know the gantry angles and directions of the treatments. We can actually calculate what's your SSD distance and compare it to your planning values for your 3D fields. So if you routinely do and utilize ODI to kind of read out the SSDs of the patient's skin, there's one other thing that AlignRT makes it easier for you. I know some centers do it, some centers do not, but we have a possibility to record it for every fraction for those patients. Okay, I'm going to go into the SRS treatments. So this is my patient browser. Normally when I have a connected connected interface to the LINAC, when I open the patient for the treatment on the LINAC, the same patient is automatically opened in AlignRT as well. So you don't need to manually filter the list or try to search for the patient's name. When you open your patient on LINAC, the same patient, again, automatically is accessed for the treatment. So when I go for the treatment screen is out there. So I have here my SRS delivery. I know my isocenter is kind of far away from my cranial area, but bear with me. I'm going to go ahead and first and try to look into my postural video-based setup. So one thing you can do on a postural video, you can also zoom into a little bit of the details to see how the patient is aligned. So I'm going to go ahead and zoom into the areas of my interest. So I'm going to look how my cranium is positioned. And I can cycle between different views if I want to see if there's a way I can, let's say, change my positioning. So you can go ahead. I know I'm a little bit in a different position. I have changes in the vertical, some additional rotations as well. But if I'm not happy with the way the patient is positioned, I can always go ahead and adjust the patient's position in real time. So let's say I see some initial roll there. I can always go ahead, look at the postural video, look at the patient's feature, and go ahead and align his head. When I'm happy with the alignment, as I see he has no mask, I'm precisely utilizing the line RT and the lab monitoring to adjust for that rotational features. So even before I put the mask on top of the patients, and of course we recommend using the open face mask for those types of treatments, with at least some opening, I can go ahead and adjust the patient's head to adjust for that particular roll, pitch, yaw, rotations of the patient's head prior to doing any other immobilization. So when I'm happy with rotational adjustments, I can go ahead and put the mask on top. I, for example, do not need even to take care about the translational, let's say, component of my misalignment. I can always, let's say, take this and drive the robotic couch automatically to the isocenter. I don't need to perform, let's say, those different those translationals by hand. Let's say I did all this. Of course, I don't have a robotic couch, so I'm going to go ahead and just capture any reference. So really what I'm tracking here, I'm tracking just the position of my head area. So normally if I have the mask, I'll be tracking the opening of my mask. So I'll be tracking, let's say, my facial opening. So really we recommended, let's say, opening is to go at least to the outer canthus, include your nose bridge, include a bit of a forehead, maybe 2 or 3 centimeters above the eyebrows. And you can also include the cheeks, at least up to the area of the upper lip. You can go into here. So what I can do, and I can exclude from my region of interest, because I can freely design it, I can exclude the eyes. Because, for example, if the patient is blinking, likes to blink, because the cameras are very sensitive, they can pick up on those very small, tiny motions as well, and this can be registered. So as the speakers mentioned today, the design of the region of interest is very important, and you can freely design it according to your needs and the site you're treating. Just to show you a little bit how this is done, I'm going to pause my monitoring, and you can modify your region of interest quite freely. You can always add a new region of interest or modify existing one. By the way, you can have up to 6 different regions of interest per surface of the patient. So you can track, utilize different areas for setup, for monitoring, etc., depending on your normal departmental protocol. I'm going to go ahead and edit this a little bit. I have also a 3D photo feature in Align RT Advanced, which brings me this overlay, a photorealistic overlay of the patient's skin on top of the 3D surface. So I can learn where the patient's features are and which areas I want to include and exclude from my region of interest. So for example, if the patient has the mask opening, I can see the mask opening here. I can immediately select out the areas that correspond to that mask opening. If the patient has some non-reproducible hair that tries to move around, or the long eyelashes, or bushy eyebrows, I can exclude those areas if I wish to. So for example, I have 3 tools here. My favorite is, of course, in this case, the freehand tool, which is like a brush tool for drawing. So I can zoom in, rotate my region of interest. If I don't like some areas, I can go ahead and easily exclude it. And if I want to draw some areas into the region of interest, I can always go ahead and include some areas into it. So it's quite easy and intuitive to use. So if you ever used, let's say, any kind of digital drawing tool, it's pretty similar, and it's quite easy to pick up. I also have rectangular and oval areas. These are used to select the larger areas here, relatively larger areas, so I can draw them much easily. And if I'm sometimes happy or unhappy with the result, I can always undo, redo, or reset to original shape of my region of interest. So when I'm happy with the result, let's say, let me do a quick modification here. I can click Save. And Align RT Advanced even has the feature called ROI Tools that tells me if whatever I drew as a region of interest, first of all, has a good topography. So it's picking up good amount of patient's features, let's say the rigid features, and it's not completely flat or just like a cylindrical to cylindrical, and also if the size of the region of interest is good enough to be tracked in real time with Align RT. So when I'm happy with my results, I can always go back. Unfortunately, this is where my isocenter is because this is where the system was calibrated. Normally, it would be at the cranium. And I can go ahead and, again, track my patient real time when I'm happy with my results. I can utilize the postural video for just maintaining and looking at the patient feature, making sure the patient is staying in the same position in real time while the treatment is being delivered. And if I need to perform some non-complanar fields, let me add some, let's say, non-complanar treatments. After CBCT is done and I have captured my reference at the 0-degree angle, so let me go ahead and capture my new reference. So this is post-IGRT shifts. When you performed your CBCT, when you performed your table shifts, this is your new position verified by internal imaging. You can go ahead and track it. And when you go into non-coplanar manner, the system will actually rotate your reference as well to a same degree that you have the couch rotation, and will make sure that you are in the same position as you're rotating the couch. You will see the deltas come up and show that you're within the tolerance. I can add additional rotations here. Let me add a 10-degree rotation. And I'm seeing here that I'm well enough positioned, but there's, let's say, a 10-degree rotation that needs to be, let's say, corrected. So as soon as I rotate the couch to this amount, the table delta will go to 0. And if I'm utilizing the beam control option, the beam will be automatically started as well. Okay, so one of the other things I want to mention here, what we also have is the treatment capture feature. So the treatment capture feature is actually a 3D overlay. So the 3D overlay here is in green. This is my live surface together with my reference surface in pink. So this gives me the full information as well of where my patient is and where my patient needs to be. So since my reference is rotated 10 degrees, I see that I need to rotate my patient about 10 degrees to reach the same reference position. So it's actually also a good tool to align and to visualize where your changes are compared to your reference. Okay. All right, any questions associated to treating SRS or SBRT patients? All right, if not, thank you, mulțumesc, Flavio. Give another round of applause. And you're free to go. And also I'm gonna release your shirt. All right. So the only one thing is left for me to show here quite quickly is again a calibration and QA procedure of the machine and how easy it is to perform each one of them. I know the physicists are always anxious how much additional work there needs to be for me when I get a new system that I need to control. But again, I'm going to show you how easy it is to utilize Align RT in this manner. So in my very subjective view, the system has one of the easiest calibration and QA procedures in all radiotherapy, and it literally can be done within minutes, to be honest. So we utilize the same patterned, let's say, plate for calibration and also daily QAing of the system. The daily QA is performed once in the morning, and it has 24-hour validity. So you perform this, let's say, daily QA procedure in the morning together with the LINAC warm-up, and then you can utilize the system clinically for the rest of the day. So what the system does with the calibration and QA procedure, it checks that stability of the cameras is maintained and position of the camera stays the same with respect to the isocenter, with respect to each other as well. So on this plate, I have a few things. First of all, there's an arrow that tells me where the gantry is. Of course, if the gantry is in that direction, this is where I need to position my plate. It has crosshairs as well. So crosshairs are used to align the plate, of course, according to your external reference. Can be your lasers or can be your field light, depending on which one you believe the best. So in any case, you can utilize either of them. And also what's written here, you have 1, 2, 3, and 4. These are the main points and the main large points marked on the plate, which are like a reference points that utilized for calibrating in QA and finding initial plate position for initial calibration. So the one thing that you have to do in the morning, whether you're performing daily QA or whether you're calibrating the system, you're going in, you're setting the plate at 100 SSD. So at your isocenter, basically, so the top part is 100 SSD, and you're aligning the plate according to the crosshairs. So when you're happy with alignment, of course, I don't have the lasers here, so I'm just gonna randomly put it on the table. I can go into my main screen. So this is my main screen of AlignRT, where I have two things. I have the system calibration, which helps me to recalibrate the system, and I have the daily QA. So when I go into the system calibration, the system tells me what to do with the plate, but normal procedure is that we align the plate, make sure the bunker lightings are at the treatment level. So whatever level we're using, the lighting of the bunker for treatment, we're calibrating the system at the same lighting level. We go ahead, align the plate, and go ahead and start calibration. So what the system here gathers is, since we have 3 camera pods, in each camera we have, in each camera pod we have 2 stereoscopic cameras, we get 6 images of the plate. And in those 6 images, you can double click it to kind of enlarge it. You have 4 main blobs, 1, 2, 3, 4, marked by numbers. And then all other small blobs are automatically selected. If you see here, not visible very well, it's a very small crosshairs kind of put in the center of each blob. So initially, when the system is installed, the engineer calibrates AlignRT to the isocenter. The system asks engineer to select those 4 main blobs in order. I can clear the selection and do it again from the beginning if I ever need to. So I'm going to go ahead and select them in order. So 1, 2, 3, 4. I don't need to even click just right in the center. You can just click it within the area of the blob itself. And when you're happy, you can go ahead and click Save. And of course, when you select or define the isocenter, it will update your calibration. So a few things here. So since I've already calibrated the system, which is a necessary thing to do if I want to use the system clinically, I already defined the isocenter. So in this case, when I put my plate on the table, the very first thing it's telling me what's the difference between the prior and current calibration. So how much of a difference I have. And I have a major difference, especially in the vertical. So there's a discrepancy there. Also, on top of this, on the lower part, the system tells me, calibration procedure tells me what is the discrepancies between the prior and the current camera positions. So it looks at the relative positions of different pods. So pod 1 pod 2 and pod 3. So these are numbered ones, so 1, 2, and 3. So it looks at the relative positions of pod 1 and 2. So 1 and 2, 1 and 3, and 2 and 3. So let's say somebody went in and touched and hit the camera 1, so it changed its position. And this is why my daily QA has failed. When I go into the calibration directly, first two numbers in this list, in the lower list, will be out of tolerance. So it will show me that pod 1 and 2 and pod 1 and 3 have moved compared to my prior position. So this actually tells me which camera has moved and which camera have shifted from the calibration procedure. And if I'm happy with the result and with my calibration result, I can always apply the calibration. I can accept this change, recalibration. I can always very easily recalibrate the system. So I'm gonna go ahead and click apply. It tells me the plate calibration has successfully updated. I click OK, and the system is now calibrated. So if you disregard my talking, the whole process basically took just a couple of clicks. So you can very easily recalibrate the system. And as I mentioned, it's one of the easiest things to do easiest procedures in radiotherapy in my subjective opinion. So system calibration can be also used as a good quality assurance tool, because when you perform the calibration, if you see that everything is within the tolerance compared to the prior calibration, you don't need to apply the calibration. You can always cancel out. What this will do, this will keep the prior calibration, but will save the report of existing check. So it's a good procedure to incorporate into your monthly checks to make sure your SGRT system is staying within your predefined calibration tolerances, and optical isocenter position is maintained within the accuracy of your departmental procedures. So in my case, I can go ahead and I can cancel out. And every time I update my isocenter, of course, I recalibrate my system, the daily QA needs to be performed. So the procedure for the daily QA is pretty much the same. You align the plate with your crosshairs at 100 SSD at the treatment lighting level inside the bunker, and go ahead, and when you're ready, start the daily QA. So what the calibration, so what the daily QA does is checks against the prior calibration of the cameras and make sure if the position of your isocenter, if the position of the cameras is still the same. So it checks many different things and just throws you a one result in terms of the RMS. So tolerance for daily QA failure is 1 millimeter. So if you align the plate within 1 millimeter, the daily QA will pass. If their RMS is more than 1 millimeter, the daily QA will fail. So most of the times, since we align the plate very well, quite accurately within the table, our RMS here is quite low. Here it's within 0.1 millimeter in my case. So I have a green check mark telling me daily QA has passed. Daily QA also has a trend line. So as you are performing more and more daily checks, your trend line of the RMS is built up. You can, let's say, do a cycle here. You can show last 4 days, or you can show, for example, the trend line for last 14 days and see what was happening during the last 14 days. Maybe there's some drift or anything like it. You can also add the notes every time you perform the daily QA. You can add performed by somebody as a note here, or performed after recalibration of the system. And when they were happy and with the results, with the RMS you got, with your green check mark, you can always click done, and that actually finishes your daily QA. So again, a daily QA is quite a bit of an easy procedure. You can perform it again within 2 or 3 minutes of your normal clinical workflows. Any questions? All right. Do you think it's easy or hard to use it? Yeah. Good question. So normally the cameras are very stable. So what can I think the reverse question would be what causes the daily QA to fail? Because if your daily QA fails, then you're mandated to perform the calibration. So the question is, what is the cause of the daily QA failure? Normally, the daily QA would only fail because of the cameras if somebody really moved the cameras. We have to understand those cameras are bolted towards the concrete ceiling with under the fake ceiling to, let's say, with its own supports, metallic supports. They're quite stable as per se as they are, and normally the daily QA is also passing, and you don't need to recalibrate. So what my recommendation to the end user is to check for the plate calibration, the parameters of your optical system. So if within your monthly QA you're performing, let's say, TG142 tests, again, it's quite simple procedure just to put the plate on the table, align it 100 SSD, and check if your isocenter is still within the tolerance. And you can always recalibrate if you believe there's something, your isocenter is off. So if not, you're not necessarily required to recalibrate. And of course, but if your daily QA fails, then it's mandatory. So, but every time, most of the times I got my daily QA has failed, let's say call or let's say complained by the customer. I tell them, please check your vertical if the vertical is correct, because that's the biggest culprit. Because as I mentioned, daily QA fail threshold is 1 millimeter only, and if you're aligning the table with the ODI, that's not as very accurate. So it's hard to align the top of the plate within 1 millimeter. So it's usually users check with ODI. Sometimes they also check with the lasers, and sometimes they also check with a table vertical reading to make sure the vertical is correct. So the thickness of this plate is 12 millimeters. So if your table is calibrated at 100 SSD, if your 0 is 100 SSD, your table reading should be about 12 millimeters below 0. So they say, okay, it's 13 now. So yeah, just go 1 millimeter up and your daily QA will pass. So, okay. You're also to come closer and do your own investigation. So it's free to use. You can break the system if you want to. No, truly. You can go into the menus, check what's in the settings, try to go into the patient browser, calibration, QA screen. Please, if you want to try it, you're welcome to try it. If not, thank you for attending my demo session. I'm again very happy to be here once again in Cluj, in Carpathian Mountains, beautiful mountain scenery. And thank you very much for coming and attending the SGRT community meeting in Romania, the very first one. Mulțumesc!